Okay, fine. So I think all of you can see me and visible, and I'm visible. So welcome to yet another session of Doc Tutorials and RRM, and we are going for the completion of the offline class that we had in Chennai. And the only topic that was left out was cutaneous lesions and malignancy. So here we are, and we'll finish this class today in about 2 hours time. So welcome, my friends. Thanking you all for taking the time out to join me today because I planned the class yesterday. Unfortunately, got held up with an emergency and I couldn't make it yesterday. Got back pretty late, so I apologize for that. And without much ado, let's start the class now. So skin lesions, if you look at it, are a widely variant kind of thing, but usually you get a few questions from them, and these are some kind of like sitter questions that we were discussing. Usually the answers will be pretty straightforward. You can crack it just by knowing the basics. There are some what you can say as small focus but high intense area. Small focus in the sense that number of questions that keep coming from these areas are pretty restricted, and you can easily score over them right from the time of our MBBS exams, when we used to have these NEET PG series called as SARP examination, skin anesthesia, radiology, and psychiatry kind of question. So skin tumors still form a major portion of that. So let's get on to the question. Like usual, I'll be discussing a little bit about the question, and then the options will give the answers, plus we'll be having the explanation also there. So this is again taken from Bailey, Sebastian, and Schwartz. So most of the questions here will be enough to cover your NEET SS portions overall here. Right. So most skin tumors originate from. So if you look at this as the answer here, then you will know that the basal layer. Now, what are the layers of the skin? So there are 5 layers of the epidermis of the skin. Like, basically there is dermis and epidermis. That is something that we all know. In the epidermis, there are 5 layers. So you have the basal layer or the stratum basale or the stratum germinativum. So these are the various layers that are used for the stratum basale, stratum germinativum, the basal cell layer, and also sometimes called as the Malpighian cell layer of the epidermis. So all these Malpighian layer that is not mentioned here, you can take that as well, Malpighian layer. So all these are the various names of the stratum basale or the basal cell layers. And we find along with this, we have the melanocytes which are present in the basal cell layer. They are also derived from the neural crest cells. Now we have the Merkel cells, which are the light touch mechanoreceptors. They are found in the basal cells. Now almost all tumors, they originate from the basal cell layer. Now, if you start from top down, it will be stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and then stratum basale. So stratum corneum is basically the layer that provides the protection against your UV radiation. That is the significance of it. Skin, as 5% only is epidermis. The rest of it is dermis, which is a lot of fat and reticular dermis. And then you have the papillary dermis and the reticular dermis. So the papillary dermis will be in terms of papillae structure, and then the reticular dermis will be interwoven fibers. So that is how you'll have the dermal layers, and that forms the majority of the thickness of the skin. Epidermis is usually only the superficial layer, and the epidermis and mild bit of the dermis is what will be removed. A small portion of the dermis is what will be removed when you're taking the skin graft. That is another point that can come up. I think Dr. Ujay would have mentioned it during his plastic surgery lecture. So stratum corneum, the important point is it protects against the UV radiation. Then you have the stratum lucidum, also called as the clear cell layer. Then you have the stratum granulosum or the granular cell layer. Stratum spinosum. This is significant because you have the keratinocytes which give the appearance of the stratum spinosum, the spiny cell layer, and this will be involved in the keratin production as well. And you also have something called as the Langerhans cells which are present here, which serve as antigen presenting cells in various areas of the body. You have various antigen presenting cells. So whenever any extrinsic antigen is there, that is taken up by these cells and then put up to the T cells to the immune system. So this antigen presentation function is by the Langerhans cells, which are variations of the dendritic cells. They are classically, found to have something called as the Birbeck granules. And what is significant in terms of carcinogenesis is UVB radiation, ultraviolet B radiation destroys the functionality of the Langerhans cells, and that might be one reason why you have the development of various kind of tumors when you have exposure to UV radiation, especially UVB. So UVB destroys the Langerhans cell layer functionally, and so the immune function of the skin is lost a bit, and that leads on to development of these various types of malignancies. Right. And the thickness is, it varies from very, very thin as far as the eyelids are concerned to very thick as far as the palms and soles are concerned, where it is almost 1.5 centimeter or 1.5 millimeters thick, and the rest of the areas it's around 150 microns, 75 to 150 microns cells. And there are another group of cells which are present in 10% of males and females in the epidermal layer. This constitute 10% of the cells, that is known as the Toker cells. Now, what are these Toker cells significant for? They are possibly theorized to be the origin of the Paget's disease. So we saw about the Paget's disease when we were discussing the breast malignancies. So in Paget's disease, we know that it starts from the basal cell layer, and then you have epidermotropism. You have the large PS positive Paget cells that go up in the various layers of the epidermis. So this kind of PS positive large clear glycosaminoglycans containing cells. So the origin is supposed to be from the Toker cells, the cells known as the Toker cells. Right. Now, if you take up the anatomy and function, taking it a little further, you have things like angiosome. Okay, so the dermis, you have type 1 collagen, type 2, type 3, and type 4 collagen. So the normal ratio is basically type 1 is the dominant type. That is the 9:1 ratio. You have type 1 collagen, which leads to the resistance of the skin. The skin cannot be penetrated. It cannot be easily, unless you have a sharp object, you cannot really crush and penetrate the skin that easily. So that resistance of the skin is due to the presence of the type 1 collagen in the skin. Now, infections, we all know Staph aureus is the most common one. And this is again a common thing. What is the role of melanosomes? What is the role of number of melanocytes? So color is due to the type and distribution of melanin. So higher melanosome creation and storage in melanocytes. It is not the number of melanocytes. It is the melanosomes that are important. It's not the number of melanocytes. The melanocyte number is pretty much standard. So you have eumelanin and hypermelanin, two types will be there. So depending on the type of melanin, you get the skin pigmentation variation between the Caucasian population, the Indian population, the African American population. So based on that, you can have the variation in the color. So that will be determined by the melanosome creation and concentration and their storage in the melanocytes. That leads to the variation in the color. Now, hair follicles again are important as invaginations of the epidermis. That is responsible for the pod-orange appearance, as we already discussed in carcinoma of the breast, where the interfollicular tissues are the ones that will be edematous. The hair follicles are already fixed. So they are kind of like pulled down and they cannot be really changed. And then sweat glands are present all over the body except in one place, that will be the lips. So if you find during any kind of cholinergic stimulation, also you will find that there is a lot of sweating that happens all over the body except in the lips. The lips cannot. You will be constantly moistening your lips. Even in your exams, you might be sweating, but your lips will remain dry. You will kind of keep doing this. So that is because there are no sweat glands as far as the lips are concerned to maintain the moisture. So this is under the cholinergic stimulation. So you have two types of sweat glands. One, the normal type, which is known as the eccrine sweat glands. And then you have the special type, which has got to do with, your pheromone function, your reproductive function, the specialized glands as we call. So they are more common in the axilla, the groin, and any of the sexual function bearing areas. So these are known as the apocrine sweat glands. So these apocrine glands is the one that will have, which are under the adrenergic stimulation. So the cholinergic stimulation is generally important, but for the apocrine glands, it will be the adrenergic stimulation that will be more important. So cholinergic and adrenergic variation in terms of sweat glands that we need to be aware of, that may come as a question. And then of course you have something called as the choke vessels or the angiosome. So angiosome is the terminal functional vascular unit of the skin. So you have the epidermis and the subcutaneous fat, and through this you will have the vessels and the perforators that will come, and this is the variation of the flaps. And then you will have the choke vessels between these two. So when you have, myocutaneous flaps, these are the ones that utilize the function of the angiosome. The functional blood supply based on the perforators is based on the angiosomes, with the choke vessels acting in between these two. If the choke vessels are lost, then you will have the development of your, fat necrosis. I mean, your flap necrosis is bound to happen whenever you have the uh, choke vessels that get damaged. So otherwise, areas of flap necrosis, you will find that one area is good, other area is bad. So generally, the blood supply from the surrounding areas will take over to some extent. But if it doesn't work, then you will have to kind of like, blame the choke vessels for them if they are not functioning properly. So these are all some various questions that can come. Common questions that usually tend to come are from the layers. Which layer does it commonly come from? Then they have asked the type of collagen that is present, type 1 versus type 3 collagen. And then Langerhans cells have come at times. And then with regard to Toker cells, that is again a significant, that has come once, I think, in your examinations. So all these are various questions that have come, and potential other things that have not come so far, but I think are important are the Langerhans cells, where you have the UVB destroying them functionally, and the uh, questions like choke vessels and angiosomes. So these are all questions that can potentially come as MCQs for you. Now, which of the following is a autosomal recessive condition? Is it NF1, xeroderma pigmentosa, Gardner's, or Gorlin syndrome? Now, as a thumb rule, I will put it this way, that all syndromes, if you don't know the answer, then it is something which is autosomal dominant. Most of the conditions will be autosomal dominant, as I already mentioned that tumor suppressor genes will be having, where even a one functional unit is enough for you to have the function of the gene. So it is usually autosomal dominant type of inheritance. The only recessive mode of inheritance, so there are only a few conditions which will be different. So that if you try and memorize, that should be enough for you to remember the answers, and you will know that that is not the one. So here the answer is, of course, the xeroderma pigmentosa. So it is one of the congenital disorders, xeroderma pigmentosa, which is related to the PTCH, or the patch gene. It is called as 9q, the long arm of chromosome Q. That is the one which is going to be involved. So here you have a very, very high risk of all type of skin cancers. So this one is an autosomal recessive inheritance, and you get multiple skin cancers, and there is a very high mortality even by 20 years. So there is quite a high degree of this one. So this one involves the Q9Q gene. Now remember, most of the conditions, the cutaneous conditions which are familial inherited ones, are all related to this locus. This 9q locus contains a lot of genes related to them. For example, you have an autosomal dominant condition which is associated. The autosomal recessive is XP. The autosomal dominant condition is something called a Ferguson-Smith syndrome, where you have self-healing squamous cell carcinoma, which will be inherited in an autosomal dominant fashion. And then you have the Gorlin syndrome again. Gorlin syndrome is again based on the tumor suppressor patch gene, patch protein. So this one is in the 9q22 locus, which is inherited in an autosomal dominant fashion. So here you will have multiple basal cell carcinomas which are common. This is one condition which is specific for the skin cancers. Like Ferguson-Smith is for squamous cell carcinoma. You have Gorlin syndrome, which is based on the basal cell carcinoma, which is probably the most famous skin condition other than xeroderma pigmentosa. Here you will have multiple BCCs, you will have hypertelorism, bifid ribs, palmar pits. These are kind of very characteristic of the syndrome. So they may give you the picture of palmar pits. I'm sorry, I don't have a picture here. I downloaded it somewhere. I'll share it later on in the PowerPoint or something like that. So there are palmar pits that will be fine. So that might be a syndrome that might be given for you. So you will have palmar pits, you will have molar cysts. So all of these are some things which are a feature of Gorlin syndrome, which is an autosomal dominant patch gene 9q22 locus, multiple BCCs are the most common cause. So these are some of the inherited syndrome. And of course, our own common neurofibromatosis type 1, you have the multiple neurofibromas of the skin, the presence of leash nodules, the presence of these are the congenital neurofibromas that you find, and then these are the caffeole macules that you find, and multiple. Usually, it will be more than 5 centimeters, more than five in number. Uncommon areas you will find entirely distributed through the body. So all of these you can find in your neurofibromatosis. So it is based on it is again an autosomal dominant syndrome, which is based on your chromosome 17. So chromosome 17, more than 5 caffeole spots, presence of leash nodules, autosomal dominant inheritance, and it can be at times sporadic also. Most of it is congenital, but around 30% can be sporadic inheritance also. So all these are the various congenital disorders that are associated with your cutaneous tumors. You have Gorlins and your xeroderma pigmentosa have been asked multiple times, and the famous Gardner syndrome, which is the FAP variant 5q22, is also associated with epidermoid cysts, osteomas, with lipomas. So all these are something that can be found as a feature of your Gardner's syndrome as well. Again, you will have desmoid as a feature of FAP, which is considered a cutaneous, subcutaneous tumor, sarcoma, that variety it comes, as we already discussed in the sarcoma chapter. So all these are things that are associated to skin and subcutaneous tissue as far as your inheritable syndromes are concerned. Right. Now going on to some benign conditions. So Steven-Johnson syndrome. So which is the false statement here. So SJS is something where less than 10% is involved and occurs within 8 weeks of initiation of a new drug as a macular rash. Positive Nikolsky sign with lateral pressure causing separation of the dermis and epidermis, mucous membrane in 20% of cases involving the various mucosa, which is the false statement here. The answer is the mucous membrane involvement is seen in 90% of cases. Almost all patients with Steven-Johnson syndrome will tend to have your involvement of the mucous membrane. So mucosal involvement is one of the characteristic features of your Steven-Johnson syndrome. So when the involvement of the body surface area goes to more than 30%, then you call it as TEN, toxic epidermal necrolysis. TEN syndrome and your Steven-Johnson syndrome are different based on the area of skin involvement. More than 30% and less than. SJS is generally for less than 10%. Between 10 and 30, there is no clarity. This is the definition which is given in Schwartz. Between 10 and 30, there is no clarity. So it is about basically less extensive with Steven-Johnson, more extensive is going to be your TEN syndrome. And mucous membrane involvement is seen in almost all the patients. The Nikolsky sign is basically when you have something and where you exert a lateral pressure. So you have a lesion here and you press like this laterally from side to side, you press it. Then what tends to happen is this epidermis will tend to get separated from the dermal region in patients who have your toxic epidermal necrosis. So this you can see vancomycin induced 10 kind of syndrome, so that there is an anti-shear dressing which is placed here with silver nitrate. So the silver nitrate dressing is going to be placed here, and some protein which is related to that is known as the granulysin. So it granulosa cell layer or even deeper it goes. So the granulysin is the cytotoxic C cells secrete this, and that is going to lead on to the development of your TEN syndrome and your Steven-Johnson syndrome. Usually happens within 8 weeks by a macular rash initially, and then followed by blisters and then bullae. So this will be the sequence. You can see that there is erythema here, there is some blistering, and then all these coalesce together to form bullae, which can peel off by the positive Nikolsky sign. I think Steven-Johnson syndrome has come once in the examination. Not a very common question, but then they do tend to ask questions from a lot of the benign areas as well. And that is why I've just highlighted the important points here. I will not get into the question here. It's basically which is about traumatic skin injuries. So dog bites are always allowed to heal by secondary intention. Acid causes deeper injuries than alkalis. Common site for pressure necrosis. Most common site is the ischial tuberosity. And stage 3 pressure sores are managed by debridement and flap cover. 1 and 2 require conservative management. The answer here is, though we might all think that the most common site is actually the sacrum, we find that in literature, at least in Schwartz, what is quoted is almost 30% is in the ischial tuberosity. I have actually practically seen mostly in the sacrum. That, according to me, is the most common. But then they have mentioned clearly that, in Schwartz, at least it is mentioned as ischial tuberosity is the most common, followed by the greater trochanter, and then you have the sacrum. So sacrum is only third in the list according to Schwartz. Okay. Now the pressure source, the stage 1 is just a non-blanching erythema. So when an erythema is there, blanching is when you press it, the erythema get released. That is branching erythema. So in the pressure sore, it is considered to be a non-blanching, which is the first stage. Second stage is partial thickness with formation of blisters and dermal exposure will be there. Stage 3 is the full thickness invasion extending down to the fascia and without undermining. Now, remember that stage 3 can be managed by vac dressings and supportive measures. It's not always necessary to plan for a debridement. Stage 4 is the one which is full thickness down to the bone with necrosis of muscle, bone, tendon, etc. The very bad bed sores, like for example, this is a stage 4 bed sore where everything is down. You can see that the fascia is already starting to necrose, and it's probably the sacrum which is seen there. So that kind of thing you cannot manage without a debridement and a flap cover. So anything less than this without involving the fascia, it is down to fascia, but the fascia itself is not started to necrose, then you can plan for a vac dressing and you can manage it like that. So that is the management of pressure sores. This can come as questions, either the staging or the management. Both of these have come at times as examination questions. Now, when you talk about dog bites, usually we know that the dog bites are managed by secondary intention, but very superficial bites which can be managed by primary suturing in cases in cosmetically sensitive areas like the face and all that. Suppose you have a small cut and all where it doesn't look there is too much of contamination, then you can plan for a primary suturing as well. After thorough debridement of that area and irrigation, you can plan for that. And what we should know is like human bites are also dangerous, and they have a higher anaerobic load of almost 1 lakh colony forming units, as they say. It's a really bad thing. Our oral cavity, even if it is well maintained, is something that has a high bacterial load, always needs antibiotics. And this is the important infection that we get this capnocytophaga canimosis. That infection is common in your immunocompromised host. And cat bites specifically, just remember, cats love milk. Milk is Pasturella. So that is the way you can remember what bites, what species are present in cat bites. That will be the Pasturella species. So with regard to acids and alkalis, I think all of you are aware already that acids, though they immediately cause destruction, they form an eschar. The coagulation eschar is formed because of coagulation of proteins, and because of this, they are less penetrating. On the other hand, alkaline burns are much more deeper because of liquefactive necrosis. This is a commonly enough questions. I think that has come 2 or 3 times. And in general, for both, the management is going to be dilution, wash thoroughly with saline, with neutral solution, or with bases, depending on what we are having and in hand. So that kind of thing can be done for management of these patients. And the duration of exposure is going to be much higher for bases. You have to literally dilute it or keep irrigating it for almost 2 hours as far as alkaline injuries are concerned, whereas acid injuries, you need about half an hour to 1 hour for treatment of these cases. Now, Fournier's gangrene has come multiple times. Which is the most common organisms? Is it staph, streptococcus, proteus, and bacteroids? The answer is your group A beta hemolytic streptococci. Uh, it is actually a polymicrobial infection. We all know that. And necrotizing fasciitis, Melny's gangrene, Fournier's gangrene. There are multiple areas, multiple names are given. So Fournier's gangrene, of course, in the scrotum. Melny's gangrene is there. Necrotizing fasciitis usually involves the abdominal and trunk muscles, sometimes in the extremities as well. Fournier's is, of course, in the scrotal areas. It is a polymicrobial synergistic infection. Now, most common infection is your group A beta hemolytic streptococci. Now, other than that, what are the other organisms which can be there? You can have the staphylococcus, you can have Clostridia, you can have E. coli, Pseudomonas, Proteus, Bacteroides. All these species are polymicrobial. Now, there is another classification which is given in Schwartz with regard to three types of your necrotizing fasciitis. The type 1 by Clostridia, type 2 by your, which is the most common type, which is the group A beta hemolytic streptococci, which is the most common. And MRSA is also becoming common, is what they have mentioned. Type 3 is specifically with exposure to salt water and seawater. That is your V. vulnificus. The Vibrio vulnificus is what they have mentioned. So type 3 is your V. vulnificus. So type 1 is Clostridia, type 2 is beta hemolytic streptococci, and type 3 is Vibrio vulnificus. So saltwater exposure is specifically mentioned as far as type 3 is concerned. So that is another potential MCQ. So whenever we have any kind of this necrotizing fasciitis or Fournier's gangrene, the only treatment is, of course, the thorough debridement till you get a bleeding edge. Don't be conservative when you have a patient with a necrotizing fasciitis. This is again not just an exam point, but a practice point as well. I have lost one of my patients to necrotizing fasciitis. I still can't believe that it happened in hospital, in a sitting where multiple antibiotics were given for the patient. It was a radical hysterectomy that we did, so there was no bowel contamination, nothing. We actually went in because there was a lot of foul smelling discharge. We thought there is a bowel perforation somewhere. We did a laparotomy. Laparotomy was negative. Then we saw one small area where it was looking like it was non-viable, and we started dissecting in a sort of like an extended fan and steel, what we call as a Maillard incision. Then we saw the upper part of the Maillard incision had a small one necrotizing area, and then it went all the way up till the chest wall. So it was a very bad experience. Still, imagine from the fan and steel area till the chest wall, you have completely, there is a loss of skin, and not the skin, it was actually the subcutaneous tissue and the rectus and everything, which was completely gone. We kept debriding. We couldn't, we managed to reach it and we could do it. And, rectus sheath, we completely removed. Part of the rectus muscle was removed. Partially, we closed it and we came, but the patient did not survive. Very terrible experience, and all of you can actually identify it. Your nose is the best indicator. When you smell it, you can't really forget it. That putrid odor, as we call it, that will be very, very classical in your beta hemolytic streptococci or any kind of thing. Basically, whenever you have this necrotizing fasciitis, so beware. Whenever you get the smell, open out the wound widely and see, because there will be only pockets where it might actually have liquefied and cause this one. It might be just having induration. That is another thing. The edema and induration beyond the level of erythema. So only mild erythema, but you might find a lot of erythema and induration with a woody hard texture much beyond the edges of the wound, and disproportionate pain might be there. So these are all features that will alert you, and it's a very, very fatal condition. Almost 50% mortality is there. And the only treatment first that you have to do is to debride to the viable bleeding areas. Then, of course, you go give a combination of, various drugs, clindamycin, penicillin-based groups, clindamycin. A lot of things are given. It's a polymicrobial thing, cycling, everything will be added for this patient. But cure is going to be dependent on the extent of debridement and, of course, the patient coming out from sepsis. And this, you can just remember this as a criteria, LRI neck, that is the lab risk indicator of necrotizing fasciitis. So what are the criteria? There are 6 factors. You use sodium, hemoglobin, creatinine, glucose, CRP, and WBC. Unlikely to come as a question, but since it's there in Schwartz, I thought I'll put it up here, because of late they are asking a lot of questions from Schwartz in NEET. So that is one indicator. You get hemoglobin, creatinine. Commonly what we do CBC. So in that you take the hemoglobin and WBC. These are the two common things. Then RF we do. RFTs will include including usually the electrolytes. So you look at creatinine and sodium in that. And then of course the inflammatory marker of CRP and glucose. So when you look at all these together, based on this, the scoring is done. Score of 8 or more, then it is a high score. That is considered to be a high risk for indicator of your necrotizing fasciitis, or I think it is possibly a sort of like a indicator of a very significant inflammatory pattern that is going on. And then you have this one other variant called as the purpura fulminans, which may come as a image based question for you, where the peripheries there is vascular, microvascular, and macrovascular angiopathy. Commonly happens in children. Again, Neisseria and varicella are the common infections. And children less than 7 years, usually with an antecedent history of upper respiratory infection. All these are some of the respirating factors. This can just come as a image based question. Your purpura fulminans, where there is a vascular thrombosis and infection, and your rapid skin necrosis that is going to happen. And this is, of course, your Melanese gangrene necrotizing fasciitis involving the face. That is no, not very common. The abdominal one is more common, but that is the other variety that you have here. Now, what is the cylindroma? I'm sure all of you must have heard of the cylindroma. The cylindroma is basically a turban tumor. Most common location is the scalp, and it's an eccrine spiroadenoma. So these are the skin adnexal tumors. Of course, the management is by surgery. That's not managed by radiation. So when you look at other lesions which are there, so then you have your adenoma sebaceums or the bone wheels disease, tuberous sclerosis. These are the various names that are given for that. It refers to the facial angiofibromas. Usually happens in this particular, in this malar area is where it will commonly happen. And I think I have a couple of pictures in the next one, where you will have pictures of adenoma sebaceum, rhinophyma, and cylindroma. Cylindroma is the eccrine spiroadenoma, which is present as a turban tumor in the scalp. Management is a wide excision surgery. So other symptoms that can be present are hyperhidrosis, sweaty palms. So that is a very common thing. Not I mean, we all get it, that's different, but chronically being hyperhidrotic like that. So there the treatment will be by Botox injection or by transthoracic sympathectomy. You take out the sympathetic stimulus and then it subsides. Then lipodystrophy and lipohypertrophy and atrophy, these are common with insulin injections, use of HIV protease inhibitors, and transplant recipients. All these patients can have lipohypertrophy or lipodystrophy. Uh, I'm again sure that we have a picture somewhere in Bailey or in Sebastian. So that picture you can have it, because that can be one of the image based question. And of course, the hidradenitis suppurativa, it is also called as acne inversa. This of course occurs in the area of your apocrine sweat glands, common in diabetics, which is uncontrolled. Then you will find a kind of like brawny induration and edema. There will be 3 stages, initially forming multiple nodules without sinuses, without scarring. Second step is when this induration and nodularity becomes starts to form, basically your sinuses. And then finally it will be the complete meshed up carbuncle kind of thing, where it all fuses together. So coalescing sinuses and abscess formation is the third stage. So this is known as the early stages. So stage 1 and 2 can be managed by topical agents and dressings and stuff like that. But whenever it goes to the stage 3, we have to plan for a wide excision with a skin graft or a flap to prevent a recurrence. So that is the way we have to manage it. So these are some cutaneous classical questions that may come. So this is of course your impetigo, classical honey colored crust, which happens due to streptococcal commonly or staphylococcal infections. You can see the erythema and the honey covered crust here. And this is of course your cellulitis and your erysipelas. So erysipelas and cellulitis are basically in the various levels. Cellulitis is of course more widespread, whereas your erysipelas is a more localized in the superficial dermis. So impetigo we already saw, erysipelas, cellulitis, and folliculitis is again a contained thing, usually contained by the hair follicles and nowhere else. So these are the streptococcal infections that happen here, and treatment is antibiotics. And in cellulitis, initial treatment, we don't actually go and excise that area, treat with antibiotics. And if it doesn't respond or one area of pocket of pus forms, that is the time when you have to do a IND. Initial thoughts were like many people used to say, whenever there is cellulitis, do an IND, because IND doesn't help. Lot of times it will be only induration and thickened edematous fluid which will be present in the skin and subcutaneous tissue without having any pus at all. So don't sort of like, put your nicks in earlier. Be a little less aggressive. Start off on antibiotics. If it still doesn't resolve or it forms a localized collection, that area you can either aspirate or you can see. And again, you can put in a needle, a white bore needle, the blood needle as we call it, that can be used to aspirate and see if there is pus which is coming. If it is coming, then you can try to aspirate it completely, press it and take it out, and then sort of like treat with antibiotics. If it is more widespread and boggy, of course at that point you can go for your IND. So this is of course your pyoderma gangrenosum. How do we know? Classically, you can see the ulcerated lesions and with a violaceous edge. If you can look more closely, this edges appears to be violaceous. The violet color edges are there and they are undermined. It is kind of like going in, that overhanging edges as we call them, or the undermine edges. The purple undermine edges happens in your pyoderma gangrenosum. This is again, you can see that there is ulceration, there is purpling. All this is very classical of your pyoderma gangrenosum. So this happens usually in inflammatory bowel disease, IBD, also as a part of Wegener's or rheumatoid arthritis, rarely in NHL. So all of these can be the various presentations of your pyoderma gangrenosum, and treatment is management of the underlying condition. Infliximab and calcineurin inhibitors, all these are used in treatment, and you go ahead and you treat the condition like this. It's again a image based question that can come up more than anything else. Okay. So this is the adenoma sebaceum that I was alluding to. So you can see clearly that there are multiple, tuberous sclerosis nodules which are present here, usually in the nasal, perinasal, what you can call as the angiofibromas in this area. Treatment is by pulse dye laser and scalpel removal. And this is of course the trichilemmoma. So nevus sebaceous of Jadowson. So that had come as a question once. So this is your trichilemmoma, happens in the verrucous nevus, which will be present. This kind of verrucous formation, you can see that it is verruciform, like a verrucous carcinoma like appearance. That is your nevus sebaceous of Jadowson, and there is a small increased risk of formation of malignancy in this. And this is of course your classical rhinophyma, the thickened bulbous nose. If people are favorites of Tinsin and we have read this, there is something called Rastropopulus, a character will come, that big nose characteristically will be present. So I am reminded of Rastropopulus whenever I see this rhinophyma. And typical, it's in an extreme form of axonal rosaceae, common in males, and there is a very small risk of basal cell carcinoma, around a 3% risk of having basal cell carcinoma as far as acne is concerned, as far as this your rhinophyma is going to be concerned, right? And these are of course the milia. So you can see the common milia which is present here, and here you have the scrotal sebaceous cyst. The milia are basically your keratin retention cysts. You can see that in sun exposure, sunlight, and you have seen those Nicel ads in previous times. I don't know whether you see that, you will get that skin heat blisters kind of thing. So that is your milia, and of course these are your scrotal sebaceous cyst, epidermal cyst, which is common, and you will find that it has got a punctum, and in the eyelid it will present as a meibomian cyst. It arises from the sebaceous glands, and you will get that small thing with a punctum. Usually it will be slightly bigger when it comes in the sort of like extremities or in the back and trunk, etc. This is the scrotal sebaceous cyst. Now, use of skin substitutes. When we talk about skin substitutes, acellular dermal matrices need removal prior to SSG if they are temporary. Autografts, including SSG and full thickness skin graft. Allografts are taken from human organ donors. Acellular dermal matrix are always from allogenic sources. So which is the false statement here? So as I said, whenever always or never is there, usually that will be the option. So that is the option here. So ADM is acellular dermal matrix. Now these are important in various forms of reconstruction where you need a sort of cover. It can be cutaneous in extensive burn injuries. It can be in areas like, breast reconstruction we were discussing, where we were talking about the implants. So lateral part of the implants, you will need the acellular dermal matrix. So the sources of acellular dermal matrix can be allogenic, which is from other humans, or it can be xenogenic. It can be from other sources like, they're basically composed of collagen, elastin. Collagen is the main thing. Other than that, elastin and other things are also present. And most of them are permanent. You don't need to separate them, but there are temporary ADMs also which need removal. And you you have an incorporation that happens within 1 to 2 weeks. They act as a bridge to a graft whenever it needs exposure of exposed vessels, nerves, without a perineurium, without a perichondrium, and all that is there. Then you may need to temporarily put this, and after that you may put on an SSG. That is kind of thing which you will have. So the four types are, what you have are the autografts, which is taken from the patient's own body, like a split skin graft or a full thickness skin graft. Then allografts, which are taken from other donors. You have skin banks which are available, which can substitute, and you look at that as the source. Xenografts, which can be taken from other animals, and of course tissue substitutes like ADM. Commonly what is used is autografts or your ADM. Just excuse me for a couple of minutes, guys. I just got a phone call from the hospital. I'll just attend that. Just a couple of minutes. Yeah, friends, sorry about that. We can get back to the class. So basically, you have various types of skin substitutes which can be used. You have allografts and which are the most commonly used ones, which is either your split thickness or your full thickness grafts. SSGs, of course, are more commonly used than your full thickness grafts. And ADMs are becoming more popular. And you also have what you can call as collagen, which is available. There are also other tissue substitutes which can be used in patients with extensive skin lesions. And more often than not, you will need them in the management of extensive injuries and skin in lesions. Now, actinomycosis again is something which is given in Schwartz. So I just straight go on without discussing the options here. So the characteristic feature that you have is the demonstration of the sulfur granules, the gram-positive filaments. You will have the filamentous forms, hyphae, like almost like what you get in your fungal infection. So that is the kind of thing that you will have, along with the sulfur granules on histological examination that shows the diagnosis of your actinomycosis. So the most common is the cervicofacial forms. So the neck and the face, that is the cervicofacial, is the most common thing which happens in almost 50%, especially this area. The paramandibular areas are very commonly involved. The organism, of course, is the Actinomyces israeli. Management is usually by IV antibiotics, usually penicillin. Penicillin is kind of very sensitive for this. Surgical management is done when you don't have a good response to IV antibiotics, and if there is extensive necrosis, then you plan for debridement, and tissue biopsy is sometimes needed to rule out a malignancy. And in India, this is commonly found in South India, especially. It's known as Madura mycosis, Madura, Madurai, that South Indian district, that area, it is supposed to be very famous. It used to be. Nowadays, it's becoming less common with availability of infectious control with a lot of antibiotics and everything. But barefoot walkers and all those areas, this kind of infection is known as Madura mycosis, and that is sort of very common, and we get it quite a lot in South India. So with regard to HPV, human papilloma virus in skin involvement, uh, going on again to the answer. So if you look at it, the HPV types which are commonly found are the HPV 1, 2, and type 4. So they call the common Berukea vulgaris. Okay, so no treatment is needed, and many of them will spontaneously regress if it is those small warts. If needed, you can manage by cryotherapy or by laser and electrodesiccation. Then you have this epidermolysis verruciformis. So this one leads to an increased susceptibility to squamous cell carcinoma in the cutaneous warts. And the infections which you commonly have are commonly caused by your HPV 5 and 8. Remember, 16 and 18 are the mucosal types. They are not caused by 5. They are not something that causes the cutaneous SCC. Cutaneous SCC is linked to HPV 5 and HPV 8. So human papilloma virus, if you look at the option 1 and 4, commonly cause the palmoplantar, that is correct. Epidermolysis verruciformis, increased susceptibility to SCC happens, but it is not 16 and 18. The type is actually 5 and 8. And plain warts on the face and dorsum of hand are caused by HPV3. And this is also a true statement. And Verrucae vulgaris will often regress spontaneously. Now, these are, I know, a little kind of like boring areas, but these can be like, short spotter MCQs that you see them immediately, you can get them right. You can just flip through as notes. And remember, HPV cutaneous has come as a question with regard to cutaneous forms, that 5 and 8 is important, not 16 and 18. That has come as a question in your NEET examinations for you. Now, HIV cutaneous manifestations, if you look at it, the most common cutaneous malignancy is BCC. Kaposi sarcoma has a prevalence of 30%. Most common viral cutaneous infection is HPV, and acute retroviral syndrome following inoculation happens in, half to two-thirds of the patient. So the most common viral infection is not HPV. As I already mentioned, the HPV cutaneous infections are less common. They involve the mucosal surfaces like oropharynx or your cervix. So these are all mucosal lesions. They are not cutaneous lesions. It is the herpes simplex. Like in other places, herpes simplex is the most common cutaneous infection you get in HIV also. The cutaneous malignancy overall, though Kaposi sarcoma is prevalent in patient with AIDS, the most common malignancy that happens as a cutaneous malignancy is BCC. The risk is around 5% to 6% of cutaneous malignancy. The prevalence of Kaposi sarcoma is 30% because it is something that, kind of like usually is an indolent disease present over a long period of time. Long standing HIV turning to AIDS, there you will have Kaposi sarcoma. So the most common malignancy associated with cutaneous malignancy is BCC. It is not Kaposi's sarcoma. Okay, so Kaposi sarcoma is usually something which is prevalent rather than as an incident infection, whereas BCC is the one which will be more common as a cutaneous malignancy presentation. Immunosuppression again leads to more commonly development of your cutaneous carcinomas. Now getting on to the pre-malignant and the malignant lesions here. So the interesting part, and this one what we have is on actinic keratosis. So they can regress spontaneously. 30% of actinic keratosis will transform into invasive squamous cell carcinoma. 60 to 65% are believed to originate from actinic keratosis. Treatment can include, laser surgery, cautery, dermabrasion, 5FU, excision, all of these. So which is the false statement. So looking at the options, all these are there: excision, 5FU, cautery, dermabrasion, all these are options. Are they most of them commonly originating from cutaneous? This one, no. The answer is true. That is also true. So only about 10 to 20% are the ones that is transforming from actinic keratosis to your squamous cell carcinoma. 30% is a little high number. Almost 1 in 3 does not get transformed. It's about 10% to 20% that gets transformed into squamous cell carcinoma, invasive squamous cell carcinoma. This is your classical actinic keratosis. Usually happens, the main faction is UV rays exposure. Typically exposed areas of the skin like scalp and face, and elderly, especially the white population, this is common. India, we don't get so much of actinic keratosis, but in the West, actinic keratosis is very common, and that leads on to malignancy in about 10 to 20% of patients. In fact, uh, you know, 60 to 65% are thought to originate, the cutaneous SCC are thought to originate from your actinic keratosis. The main risk factor is the exposure to UV rays, which, as we already discussed, will destroy your, the Malpighian cell layer. That is where it is going to act. It is going to not the Malpighian layer, sorry, the fourth layer, where it will destroy your Langerhans cells, and that will lead on to development of a reduced immunity and reduced antigen presentation, leading on to infection, to development of cutaneous squamous cell carcinoma. So they can regress at times spontaneously. They can be static, or they can kind of like progress, usually in about 10 to 20% of cases. Now, this particular entity, of course, is very famous to all Bailey users as widow dimanche, that, sebaceous horn, which is arising from the, from the scalp, I mean, from the forehead. You will see that classical picture, water carrier in Paris, that I'm sure that all of you will be aware of. So this is the typical sebaceous horn, an actual sebaceous horn you can see in the face. So the height is to base diameter. That should be, height should be more than the base diameter. Even in this, there is a risk of malignancy, so it needs a excision. So there is a 10% risk of squamous cell carcinoma even with your sebaceous horn. So when you consider the next part of it are the benign appearing nevi, these kind of questions have come in multiple times. So the nevoid lesions, as we call them. So what is this? This is the classical seborrheic keratosis. So what do you mean by seborrheic keratosis? Is a benign condition. It is the most common benign lesion. You can see that it's a waxy appearance. You can see that, it's like wax paper, that, kind of like appearance of a crinkled wax paper like appearance. So that is very classical. And when you have it, you can make the diagnosis. So this is your seborrheic keratosis. This is, of course, the classical nevus, also called as the junctional nevus. Why is it called as junctional nevus? Because it happens in the junction between the dermis and the epidermis because of a proliferation of your melanocytes or the nevus cells. Then you have the Spitz nevus or the juvenile melanoma, as it is called. Okay, usually it is benign. They can, happen commonly in the face and in the legs, usually in the juvenile age group. Excision is needed to rule out a melanoma because the features will be pretty difficult to identify. So there is also an entity called as a spitzoid melanoma. So there is an entity called as a spitzoid melanoma as well. But Spitz nevus alone, if you consider, that is a benign condition. It has got no relation to malignancy. The appearance being like that is known as the spitzoid nevus, spitzoid melanoma, which I will be dealing with in the melanoma topic. So then you have your spindle cell nevus, which will contain atypical cells, and they have a higher risk of malignancy. And this can come again as an image-based question. The halo nevus, you can see that there is a halo at the central nevus. So this will usually characteristically happen in your vitiligo. So vitellogenous patches with the central nevus, you can have your halo nevus where it will happen. And again, this has come as question, the Mongolian spot. They can give a classical violaceous large spot, usually, blue-gray by the sacral area and in slightly in the upper back as well. So all these areas it can happen. And the key is no management is needed. It has a spontaneous regression by 7 years. Remember, this number 7 is very sort of like very famous in various areas. This in cutaneous lesions, by 7 years it disappears. So remember our Dhoni Bai, and in 7 years it regresses and it disappears. So spontaneous regression by 7 years, that is known as your Mongolian spot. So then you have your giant, congenital pigmented nevus, or GCPN, or giant hairy nevus as it is called as. So this one, the description is classically more than 20 centimeters in size. So various dermatomes it will affect. In the dermatomal distribution, you can find that. So GCPN, or giant congenital pigmented nevus. So this has got a 5% risk of melanoma. So that is one classical thing that can be kept as a spotter image based question that you will have. And nevus pilus, this is known as the speckled lentiginous nevus. So this is again having a classical appearance. You can see the multiple speckling like your leopard spots that is going to be present here. So that might again be something that can be kept as a image based question. So cafe au lait spots, grossly if you look at it, it's a cafe au lait spot, but the speckle hyperpigmented appearance will be there. Management is just to observe and serially photograph the lesion. Nothing else is needed. And this is of course your atypical nevus or your dysplastic nevus, which is something where there is a risk of malignancy. Now, all of this has been asked multiple times. What are the five ABCDEs? What are the five things that will happen? So you have asymmetry. Asymmetry is basically, in shape, irregular border will be there. It's not a regular shape. That is what is known as your asymmetric shape. So you will have a sort of like a variable shape. You can see here that this is not a classical shape. It's a variable shape that is going to be there. Then border irregularity, you can see that the borders are irregular. Then color irregularity, you can see that this area is dark, this is slightly lighter, these are the lighter areas. So this kind of variation in one single mole, which is sort of like slightly larger, that is very characteristic. So asymmetry in shape, then border irregularity, then color variation, then you have the diameter. The cutoff is 6 millimeter. Anything more than 6 millimeter, there is an increased risk of having a melanoma. So cutoff more than 6 millimeter, which is going to be there. And evolving or a changing mole. So one that changes with time when you have it. So that is known as an evolving or a changing mole. So that is supposed to have all these the ABCD classical features. So this might be given as a typical image based question. All the features are present here. So your asymmetry, border, color, diameter, and your evolution over time. All these are some things that will make it more likely to become a melanoma. Again, when you have more than 5 melanomas, large nevi, especially when they are present, then there is a risk of having your atypical multiple mole melanoma. I'm not talking about the small nevi here. The large nevi, if you are having, and that is number is more than 5, then those are at a risk of this FAM syndrome, or the familial atypical multiple mole melanoma syndrome, where you will have CDKN2 mutations, which are common. So CDKN2 mutations which will be there, and that will lead on to development of melanomas. There is also a small risk of your head and neck cancers. That is the only sort of like familial condition which is inheritable, which has the head and neck cancer. The oral cavity lesions can happen. So familial atypical multiple mole melanoma syndrome is the one where the number is more than 5 and multiple atypical nevi are present, dysplastic nevi are present, then there is a risk of having melanoma. So these two questions have again come multiple times. Nevus of Ota and Nevus of Ito, both of them have come. Ota, remember, is in the face. So Oriental and in the face, Africans are more common. So V1, V2 dermato. So that is the classical one. Ota, so Ota. And then you have the Ito. So the Ito is the one which will be present in the shoulder and the chest. The same kind of pigmentation present in the shoulder and the chest. Both of these have come as questions at multiple times. It has actually come as an image-based question. I think this came as an IBQ, and this came as a classical question, which area is getting more affected. And what we have here is the classical blue nevus. Typically, you can see that the appearance is bluish in color, and usually it is a benign condition which will not have any malignant potential at all. But melanoma needs to be ruled out. So many a times you need to excise this to disprove a melanoma. And of course, the vascular lesions and the malformations that we have. This is the classical capillary angioma or the capillary hemangioma or the strawberry nevus as it is called as. It is the most common so-called the birthmark which is present. So many of them, as I said again, by 7 years, 70% will be resolving. So this is subject to spontaneous resolution. So many of them appear at birth, keep on increasing. By 7 years, they will be disappearing. Common in girls, less common in boys. So that is the characteristic lesion that you will find in a capillary angioma or a strawberry nevus. Very classical DAS question. And of course, here what we have is the port vein stain. Here what we have is the port vein stain. This one, the typical appearance, and this is the salmon patch which happens in the neck. In the neck, what we have is the salmon patch that will disappear by 1 year. The port vein stain is a arteriovenous malformation. On the other hand, the port vein stain again has come as a question. So port vein stain, the classical deep red color of wine. So that is giving the classical appearance, and this is a malformation. Again, this is distributed in the V2, V3 dermatomes and all that, but this one does not disappear spontaneously. It needs to have a laser dye management, only then you can treat it. It will not disappear spontaneously. So this is your classical port vein stain. Okay, right. So then, of course, you have these old age changes, as we call them, the Campbell de Morgan spots. Most of the elderly patients, if you look at it, if they're slightly fair skin, you will have this freckled appearance of these port vein, of these Campbell de Morgan spots. Yeah, this is again a small dermal capillary avil fistula, sun exposed older individuals, you will find it. And this, of course, is the classical spider angioma or spider nevus. So you can see that there is a central arteriole and the branches, which you can see that classically, of course, associated with cirrhosis, but can be found in pregnancy as well. And these are some common questions that can come just like that. And of course, what is this? This is your pyogenic granuloma, which gives that sharp, kind of like a malignant appearing thing. They are small nodular lesions. There is a superficial ulceration, heavy bleeding after trivial trauma. That is very characteristic, and they should be excised with some minimal margin. And these are the subcutaneous glomus tumors. So they can have the small glomus tumors, which are usually what we saw in your head and neck. So something similar to that, you can have the arteriomalous malformation, shunting, which happens in the subcutaneous tissue as well. They will, especially the ones under the nail beds, the glomus tumors can be severely painful. There will be just a black dot there. Severe pain will be there, especially disproportionate pain present in the nail bed. That is very characteristic of your glomus tumor. Yeah, now getting on to your melanoma and your BCC, the actual malignancies by themselves. So what are the types that are there? Which is the most common melanoma? Which is the most common BCC? So this is something that people tend to get confused with. So the most common melanoma that we have is the superficial spreading. That is the most common type, whereas BCC, the nodular type, is very common. So A is the correct answer here. Okay, so superficial spreading melanomas are common and nodular BCCs are common. Overall, if you take it, look at it, and without taking skin, registries into consideration, because in registries, BCCs are not reported. So overall, the most common cancer worldwide is your basal cell carcinoma. It is not reported in many cases because it will be just excised by many dermatologists and even surgeons without the need for tumor reporting. So that is the reason why the numbers are not reflected. But the most common cancer overall is, if the answer is given as BCC, kindly mark that as the answer. The answer is basal cell carcinoma because it is not reported in skin registries. Exposure to UV rays. So there are two types of exposure which can be there. One is the chronic exposure, the other one is the intense intermittent exposure. Now, these two exposures are different. So whenever you have intense intermittent exposure, that is important for development of your BCC and your melanoma, both of them. So both BCC and melanoma, they will have this intermittent exposure. That is important as far as your BCC and your melanoma are concerned. On the other hand, your chronic sun exposure is the one that lead to acne keratosis and your squamous cell carcinoma. That is important for you. So UV rays, UVA, B, C, all of them are malignant. Clinically, UVB is very significant because UVC is getting filtered by the sun, by the ozone layer. So in the earth, what you will have in the sunlight is mainly the UVB. So that is important. And, some special features are any malignant lesion in the upper lip is more likely to be BCC rather than squamous cell carcinoma. The most common subtype of BCC is the nodular or the nodulocystic type, which constitutes almost 80 to 90%. This is the classical appearance that you will have. This kind of nodular and nodulocystic appearance will be there. Raised edges, pearly edges, as it is also called as. That had come as a question once. So the pearly edges or the rolled out edges, as it is called as. So that is very characteristic of your nodular type of BCC. One characteristic of BCC, we saw that squamous cell carcinoma has acne keratosis. We'll see that melanoma has a melanoma in situ. In BCC, there is no precursor lesion. There is straight away directly only BCC. So there is no precursor lesion. And this is again another question. So this is your field fire type of, morphiform type of BCC, where you have the central healing. And I think I discussed this in some other context. I don't remember which this one, but in class I was discussing this. So you'll have the central healing area and the peripheral thing which will be more aggressive. So healing and spreading, healing and spreading. So the field fire, as you some of you might have seen some movies. In fact, there is a movie called Gods Must Be Crazy, where the only way to stop a field fire is to light a fire beyond it, so that it spreads rapidly, but at the area where the fire has already burned out, then it will stop. That's the only way to stop a field fire. So something similar is what we get. It keeps on spreading at the edge. It goes very rapidly. So that is the way that you have to do. And this is the classical field fire BCC that we will have. So you will have kind of like a very faint lesion. The edges are going to be the ones that spread. The center part will be healing. So that is known as the morphia form or the field fire BCC, highly aggressive variant. And here you have the type 4 collagenase, which is present in the basement membrane of skin and soft tissue. So you will have the type 4 collagenase being synthesized. And so healing ulcer with spreading margins, ill-defined lesion, that is the morphia form BCC. Now, what is the management of BCCs? This is subjected to a lot of controversy, whether the margin of excision is 4 millimeter, 2 millimeter, 3 millimeter, 5 millimeter, 10 millimeter. So overall, when you look at it, 4 millimeter margins, whenever they talk about low risk BCC, then the margin is considered to be 4 millimeters. High risk, the margin should be 1 centimeter. So what is this 4 millimeter, which are considered to be the low risk lesion? Anything which is more than 2 centimeters considered to be high risk. Any lesion more than 2 centimeters high risk. And again, the facial areas, the ear, nose, scalp, mask areas, as we call them, those are considered to be high risk, and associated with immunosuppression is high risk. So all these cases you have to go for a 10 millimeter margins. If it is a low risk, in the sense non-mask areas, no immunosuppression, and size is less than or equal to 2 centimeter, then you can go for a 4 millimeter margin of excision. That is good enough. So that is the clearance which is needed in your BCC. And the management is can be done usually by excision, but you can use radiation. Most micrographic surgeries especially used when you have difficult areas, like for example, this skin lesion here. So this one will probably require a very good margin control for reconstruction of the eyelid. So these kind of areas, or where it is close to them, so there you can use your most micrographic surgery. uh, what do you do in your most micrographic surgery? That is something that many of you may not be aware of. Now, just to give a quick hint, what do we do when you have a lesion like this and you're studying the margin? So you mark it as short superior, for example, and long lateral, and then you send across. So they will take bits from here, bits from here, and deep margin, anterior margin, like that they will do. So they are basically looking at superior, inferior, medial, lateral, superficial, and deep margins. So that is how the frozen sections will be usually done. So that is how the frozen sections will be usually done. Now the problem with this is you're not assessing the entire margin. So how do you assess the entire margin, whether it is involved or not? So for that, what they will do, suppose you have a lesion like this, then you keep on dissecting and you take out the entire lesion. The entire edge of the lesion is taken out, and you color code it. For example, here it might be red, here it will be green, here it will be yellow, here it will be brown. Like that you color code it. Then you give a cut here and you lay it down. So what happens? All your things, like your red, your blue, your green, your brown, whatever colors you have given, all of them are listed out here, and the entire margin is studied. So this is essentially the uh, you know principle behind your most micrographic surgery. It is also called as CCPDMA, circumferential, peripheral, and deep margin assessment. Okay, so circumferential, complete circumferential, peripheral, deep margin assessment, CCPDMA. Okay, so you are assessing the peripheral margin, and also the deep margin will be similarly taken. You will crush it. So for example, if this is the lesion, then you will crush it, so that, and then you will take a shave, so that the entire deep margin is studied. It's not just one area of the deep margin. Do you get it? Suppose you have a lesion which is there like this, and after taking the peripheral margin, then this tissue is going to be squashed. So that when it is squashed and you take a small bit, you take kind of like a tangential excision of that, and the bottommost layer is taken and that is put on a slide and studied. So then you will know whether there is any tumor tissue here. If there is any tumor tissue, then the base is inward. So this is known as your complete circumferential, peripheral, and deep margin assessment, which is classically what is done in your most micrographic surgery. So this is the one which will be done in your most micrographic surgery, and that is important. Most micrographic surgery is another name for it. The current name is CCPD-MA, or the complete circumferential peripheral and deep margin assessment, as it is called. As in difficult tumors, generally this kind of technique will be used. So in difficult tumors, this kind of technique will be used, right? So this is as far as the management of your BCC is going to be concerned. We already saw regarding the Gorlin syndrome of inherited BCC. We saw the subtypes nodular, nodular septic. You can get the superficial spreading type. You can get your, morphiform type. All these are the rarer types, but the nodular and the nodular cystic are the common types, where the margin is 4 millimeter for small lesions and 1 centimeter for high risk, low risk and high risk. High risk is what? More than 2 centimeters, anything in the mask areas, and anything where there is an immunosuppression. So these are the management points as far as BCC is concerned. With regard to melanoma, and again, I'm not sure, I think there is another slide somewhere down for peripheral palisading. One characteristic feature that you will have on the histopathology will be something called as peripheral palisading. So that has come as a question once. What is the peripheral palisading appearance? They had given a picture of peripheral palisading where you will find like a fence. It's like this kind of appearance what I have drawn here. You will see those picket fences, as they are called. You will see those row upon row of stacked fences which will be there. So this is the appearance that you will get, which is found in the periphery of the tumor. So that is known as your peripheral palisading appearance, which is very characteristic of your BCC, very, very characteristic of your BCC, right? So then going on to melanomas, so which is the most clinical UV ray, clinically. So that is, I already discussed this, UVB. Overall, if they don't ask this clinically, most dangerous type of UV, clearly you can mark it as UVC. That is the most common type, most dangerous type overall. But when you take up UVB, that is the one which is clinically present, because your UVC is going to be filtered by the ozone layer. So UVB is the clinically important one. So UVC will be filtered by the ozone layer here. So that is not going to be present. And UVB, as I already told you, is the clinically most significant form. So intense intermittent exposure, intense intermittent sun exposure, that is important for both BCC and for melanoma. Both of these are important. The type of sun exposure determines it. Chronic sun exposure, as I already said, is to do with actinic keratosis and your squamous cell carcinoma. And then, is UVA safe? No. UVA exposure, especially with more than 10 tanning bed sessions in children and adolescents, there is a 2 times increased risk of developing melanoma. So even your tanning bed exposure is dangerous. In India, we don't use tanning. We are not really bothered. Most of us are dark skin, so we like to have a fair skin. In the West, the tan skin is something that people long for. So they go to the beaches and everything, and then they do. So that is where they have to be careful, and you have to use the sun protection factor. You have the SPF, as it is called as the sun protective faction. All of you will know about SPF from seeing all the Fair and Lovely ads. The recommended is around 30. So the SPF of around 30 is needed to protect against UV rays. So SPF of 30 is what I remember. I'm not exactly sure of the number, but as far as I remember, the number is SPF 30 is what you need to prevent against or to protect against UV rays for you to not have a risk of this one. So that kind of sunblock is needed in the exposed parts of your body. And as I already said, the BK mole, the BK mole syndrome, or the dysplastic nevus syndrome, or the familial atypical multiple mole cell syndrome, or the CDKN2A mutation. This has come as a question. More than 5 moles when they are present, that is significant. So the mutation is, this is the most common mutation. Very, very, kind of like, common syndrome that is a precursor lesion of a melanoma. And which is the most common? This is in inherited melanomas, find you. Okay, so the FA triplum is the mutation which is associated with the inherited melanomas. Commonly, melanomas are highly, what I can say, as immunogenic and this tumors. So here, the mutation which is common is the BRAF. The BRAF mutation is the overall most common mutation. Just like we discussed in thyroid, the BRAF V630 is the most common mutation that is also found in your sporadic melanomas. If you take it up, sporadic, this is the most common melanoma overall that you will have. So risk factors all are there except, so Fitzpatrick type, xeroderma pigmentosa, familial history, and the Asia Pacific. This is, of course, the clear exception. Okay, Asia Pacific Islander men have the least risk of developing a melanoma. Fitzpatrick type 1 and 2 are basically the tall, blue, blonde, the Aryan ancestry, as we call. So that is the most important risk factor for developing a melanoma. Then you have xeroderma pigmentosa, as we've already discussed. All type of malignancies are skin malignancies are common, but XP is the most dangerous one for causing melanomas. And family history overall are the risk factors for developing a high risk history. Now, Asia Pacific region, men are the least commonly involved. I mean, women, actually speaking, Asia Pacific Islander women, these are the least uh, population who have the lowest incidence of melanoma after black men and women. Okay, first is of course the black men and women because they already have the melanin pigment distribution, so that prevents the melanoma. Whereas the next one is going to be your Asia Pacific Islander women because they are less exposed to sunlight, and then it is the men. So intense intermittent exposure, as I already said, is important for melanoma and BCC, and UVA in tanning beds and UVB in sunlight. Most dangerous is of course the UVC. On Earth, it is UVB, and that is one thing. The UV associated mutations are found, DNA adducts and all that you can find in melanomas, and that is how you know whether a melanoma is a UV associated melanoma. You will find it in the genetic signature. When you analyze the genes, you will find the UV associated mutations that will be commonly present. So talking about the wrong statement about melanomas, 40% happen in precursor lesions like dysplastic nevus or the Spitz nevus. BK mole syndrome associated with CDKN2A mutation in 40%, multiple melanoma and pancreatic cancer. Giant congenital nevi more than 10 centimeter increased risk of melanoma and are preferably excised. Spitz nevi with ATPR managed by wide excision similar to melanoma without the need for SLNB, which is the wrong statement here. We already know, we discussed that the option here is 20 centimeters and not 10 centimeter. GCPN, giant congenital nevi, that pigmented nevus is where it is more than 20 centimeters. So all the other statements are true. So BK mole syndrome, FA triplum, dysplastic nevus, all of them are basically the same thing. It is associated with the CDKN2A mutation, risk of melanoma, pancreatic cancer, and as I mentioned, head and neck cancers as well. And more than 100 nevi will be present. GCPN is of course more than 20 centimeters. They have to be managed by excision because of the higher risk of transformation to malignancy. Spitz nevi are generally considered to be benign, but Spitz nevi with atypia, they are very, very difficult. They are the spitzoid melanoma, so they are difficult to differentiate. So you will have to manage them by a wide excision. SLNB is not done. SLNB will be done when you think it is a spitzoid invasive melanoma. Once it is proven, then you can plan for a sentinel lymph node biopsy. And many melanomas do arise from dysplastic nevi and congenital nevi. You know, that is the lesion which is present in about 40% of cases. So with regard to mutations in melanoma, this is a question that has come up a couple of times. BRAF V600E is the most common genetic subtype. RAS subtype is the second most common subset. P53 mutations are most common inherited mutations in melanoma, and NF1 subtype is found in about 15% of melanoma. So we already know the answer to this, which is not the true statement. We just saw that CDKN2A or the familial atypical multiple mole melanoma. So the FA triplum is the most common inherited defect. We already saw that. So this FA triplum is the answer. So P53 is the wrong answer here. So all are true except, so actually there are multiple wrong types which are here. Okay, genetic. Okay, yeah, it is true only. So BRAF V600 is the most common genetic. It's not the inherited one. So BRAF V secondary is the most common genetic mutation that you identify. The second is the RAS mutation. The most common genetic is the BRAF V600E followed by V600K. 50% have V600E followed by V600K. The second most common overall subtype that you have is the RAS pathway mutations, which happen in 30% of cases, and then NF1 pathway in about 15% of cases. So just like breast, you have a triple negative type or the triple wild type here, which has none of these mutations. Basically, your BRAF, your RAS, and your NF pathways, all of them are normal, which is known as the triple wild type mutations. These are the ones that have the lowest UV signature. So UV signature is the one that UV rays cause these kind of mutations, either when they are causing mutations or the genetic changes in your BRAF V600E or RAS or the NF pathway. As we already see, NF1 is associated here. The RAS-RAF pathway, we already had a discussion in thyroid about the various areas where it will be RAS. Then you will have the RAF pathway, then the MEK inhibitors, and then you have your mTOR pathway here, PIK3 mTOR pathway here. So all these we already had a discussion on at the time we were discussing thyroid. So the RAS pathway here, so BRAS, KRAS, HRAS, NRAS, all these will come here. The next step is the RAF. This is the BRAF pathway that will be important, where you have the drug inhibitors like vemurafenib and dabrafenib, and then you have the MEK inhibitors, which are the cobimtinib and your trametinib. All of these will come here. Selumetinib, all of this will come here. And then NF1 is inhibitory for RAS. So that is another mutation type. So you have the RAS, you have the NF1 and the RAF. So RAF is the most common. RAS is the next most common, and then you have your NF1. These three together form the locus. These three together form the locus. They are the most common genetic abnormalities that you get in a melanoma, which is sporadic. Now, inherited, it is going to be, of course, the CDKN2A, which is the most common inherited mutation. PTEN loss happens in about 50% of melanomas and is the most common cause of resistance to BRAF pathway. So the BRAF MEK inhibitors, if you look at it, the PTEN mutation, this is inhibitory. So when you have a PTEN mutation, then there is a permissivity which will lead on to development of your, finally leading on to activation of the P16 and the retinoblastoma pathway and all that. So leading on to development of melanoma. So you can see clearly this picture also is important along with the one that I previously showed you. Kindly practice this, having this area also. This is again another thing where you have a very clear notation about the interconnectivity of each pathway. Where is P53, what is happening, all this is very clearly mentioned here. Each one where it is going to act, that is very clearly mentioned here. So you have the RAS pathway, then the RAF, and then the MEK inhibitors. All of this will come here with NF1 acting as an inhibitory substance. So NF1 loss will lead on to activation of this pathway. Then you have the PIK3K pathway. Again, as I already say, PIK3 inhibitors like alpelisib and tazalisib, we already had a discussion during our offline class. So alpelisib and tazalisib will act here. Then you have your mTOR inhibitors like everolimus, which is going to act here. Then in this pathway, lower down, you have the CDK4, the cyclin dependent kinases are going to be present here. So this is going to be your palbociclib, ribociclib, not important in melanomas, but in breast, you can have these in melanoma, in breast pathogenesis, this is involved. And P16 is an inhibitor, and this one in turn inhibits your retinoblastoma, which is the tumor suppressor gene. So if your retinoblastoma is lost, then cyclin dependent kinases are activated. CDK inhibitors will act and they will further suppress the retinoblastoma. So that is how the pathway works for you. This is important. Okay, so PTEN loss is again one of the commonest things that you will get in your non-familial melanoma. So PTEN loss is important in your non-familial melanomas. PTEN is important in about 25 to 50% of non-familial melanomas, and they got resistant because that is the alternative pathway that goes on. In case this pathway is blocked, then it goes on to the PTEN pathway and PIK3K pathway, and that is where you will have the origin or resistance to developing to BRAS, KRAS, BRAF inhibitors. So melanoma, if you take up young adults, this is the most common cancer. Young adults, you mean less than 40 years and beyond your teens and less than 40 years. So chronic UV exposure is important in only one melanoma, that is known as the lentigo maligna melanoma. All other types are important to your intense intermittent exposure. Chronic exposure is important only in your lentigo maligna type. The most common type, as we already had the question, is the superficial spreading type of melanoma, like what we are seeing as a picture here. So UVB exposure in natural sunlight is important than UVA found in tanning beds. So the molecular pathways, as we already discussed, the BRAF is the most common. Then you have the RAS and the NF1 pathway, and inherited mutations most common is the FA triplum in 40% of cases. Now the preferred biopsy for a 1 centimeter melanoma is punch biopsy to a depth of 4 millimeter, shave biopsy, excision biopsy with 1 millimeter margin, incision or wedge biopsy, which is the preferred biopsy in a 1 centimeter melanoma. So the answer to this question is, what are the various types of biopsies that are available, what we need to do. So here, when you have a small lesion, you generally preferably excise it up to 1 millimeter margin. That is preferred for a small melanoma. Okay, anything more than this, then you have to go for an incision biopsy, and this is the dermatological punch that I was referring to. Remember in Page's disease I was telling you, so something similar. This is the punch that you have. So you put it down into the lesion and then you roll your fingers like that, and then you punch or drill, you do to 4 millimeter depth, and this is preferred for large lesions, inaccessible locations, and all these areas. So this is the classical thing that we tend to do, and this is your punch that we take. You can see here that the punch has been taken and it is come out. So that is how you do the punch biopsy. So shave biopsy, practically many people do a shave biopsy in dermatology. We don't tend to do it dermatology because you can just shave it off the surface, but it will not yield the correct depth. That is the problem with your shave biopsy. Deep shave or saucerization, they call it, which is essentially basically going on to the subcutaneous patch, which makes it an excision without margins. They generally tend to do it. So preferable to do a kind of like a drill biopsy or the punch biopsy whenever you have a large lesion. If at all you are excising, go for at least a 1 millimeter margin for any melanotic lesion. So that is the way your excision has to be done. So this is your dermatological punch as we call it, and then you kind of stretch it and keep on rolling it, and then you take out and you actually take the biopsy and send it for pathological assessment, and that will give you the depth as well. You can see here clearly that that's the superficial layer and that's the deeper layer you can clearly make out. Right. Now, clinical question. So when you have a 56-year-old lady with a melanotic lesion, what is the uh, likely diagnosis in this kind of scenario? So is it a dysplastic nevus? It's a superficial spreading? Is it lentigo maligna? It's a nodular lesion, melanoma. So here, if you look closely, you can see that it is not nodular. It is kind of like flat and depressed only. It is not a nodular lesion. So that can be ruled out. So what about superficial spreading? That is what it looks like. Dysplastic nevus is unlikely given the age of the patient. So it is between these two. Looks like superficial, but then you have to remember that the L-triple-M type or the lentigo maligna melanoma. So that is the one where it is known as your Hutchinson's melanotic freckle. Hutchinson's melanotic freckle is the other name. Common in elderly, in the face and head and neck areas. And then you have women who are more commonly affected. It's a slow growing tumor, most common associated with chronic sun exposure, as we just discussed. And this is the one which tends to be less metastatic. Now, in melanomas, you have something called as a radial growth phase, which is the lateral spread of a melanoma, which will go on for quite a long time. And then you have something called as the vertical growth phase, the RGP and the VGP. So RGP is the radial growth phase. Then you have the VGP, which is the vertical or the depth-wise growth phase. Now, in a melanoma, normally when you have a superficial melanoma, the radial growth phase will be long. And this one is characteristic of that. The lentigo maligna one is the one where it is an even more extended, what you can say as a radial growth phase will be there till it enters the vertical growth phase. Usually by then somebody will notice and you can plan for an excision. So the most common melanoma overall and the most common melanoma in non-white patients is, we all know that in white it is the superficial spreading which is the most common. So which is the most common melanoma in non-white, and most common melanoma overall and the most common melanoma in the non-white patients. So we all know the answer is superficial spreading because we just saw that nodular is the most common BCC and superficial spreading. So it is between C and D. So among these two, which is important, is it amelanotic or is it acral lentiginous? The answer is acral lentiginous. So superficial spreading type is the one that occurs in the non-sun exposed areas, trunk and proximal extremities. These are the most common sites for a melanoma. Overall, it is around 70%. Now, acral lentiginous is the most common type in the non-white population. What do you mean by acral lentiginous? So it happens in the hands and soles and all that. So that is known as your acral lentiginous melanoma. This is of course your superficial spreading melanoma. As I said, you can see the asymmetry. The shape is not very regular. Then you have the irregular borders. You have the color demarcation. And then you have the size which is more than 6 millimeter. And of course, this is something which should have probably evolved over time. So all the ABCD criteria are present here. And this, what you see here, this is your nodular melanoma where you can see straight going down. The width is not, the radial growth phase is not much, but the depth is going to be larger. This is your nodular melanoma, and this is of course your Hutchinson's freckle or your lentigo maligna melanoma subtype. And then of course you have your acral lentiginous melanoma here, which is the most common subtype which is present in your non-white population. And again you have the melanoma which is the subungual melanoma, which will be present under the nail bed. So subungual melanomas, how do you biopsy? Again, you can do a punch biopsy. So superficial spreading is the most common type. Many arise from a pre-existing nevus, happens in non-sun exposed areas. Nodularity indicates a vertical growth phase. Nodular melanoma has a poor prognosis because the radial growth phase is very small. It directly goes on to a vertical growth phase. There is a very short radial growth phase. And so this is the more aggressive type, usually arise de novo, and 5% are amelanotic. So these are the ones that are a little different from what we usually find. They are more aggressive. They arise de novo. 5% are amelanotic. It happens in the trunk and head and neck areas, and they are usually very sharply demarcated. Lentigo melanoma, we already saw chronic sun exposure, less metastatic than the other types. What is this? This is an African with a nail change as described. What is the next excision? You got a melanotic lesion here. Will you plan for an excision till the 1 centimeter margin, till the MP joint disarticulation you do? Whether it's a 2 centimeter margin you will excise. What is the surgery that you will plan for this patient? So here is where you have to look for this classical sign. So here you can see that this is the nail fold involvement. Look at the nail fold here. The nail fold is completely normal here. whereas here the nail fold is also having the pigmented lesion and the superficial ulceration, or what you can say as the destruction or oncolysis of the nail bed is happening. So this is the thing which will be present in your subungual melanoma. In your subungual melanoma, usual type is your superficial spreading. Acral lentiginous, I'm not sure, is actually a what you can say as the you cannot call it subungual melanomas are superficial spreading in type. They are not considered to be ALMs. Okay, so it is a subtype. So subungual melanoma does not change position with time, whereas a hematoma will migrate distally. So how will you know whether it's a hematoma or not? So suppose there is a hematoma, it will keep migrating distally, whereas your subungual hematoma will not change. And again, the Hutchison sign, which is the nail fold pigmentation, as I showed you here, this nail fold pigmentation will happen, which is known as your Hutchison sign in your melanoma, in the subungual melanoma. Acral lentiginous usually happens in the soles and the palms in the Asian and African ancestry. So 25%. So this what we have here is a benign pigmentation. This is a benign racial pigmentation which does not need any management, just needs observation. That is all is needed for this particular patient. It's a classical thing. It has come as a question also once. Right, now going on to desmoplastic melanoma. So what do you mean by desmoplastic melanoma? This is one special subtype of melanoma which has got a high perineural invasion, high propensity. There is a very high propensity for a perineural invasion, and because of that there is a high local recurrence as well and needs a wide excision. I mean, almost all melanomas need a wide excision, but this one has a higher propensity for local recurrence. But one other thing is, there is, even though it's a highly malignant lesion, there is less propensity for nodal metastasis. We saw that type, no, we saw which type of breast cancer? We saw the metaplastic type of breast cancer. So in metaplastic breast cancer, high grade, high local recurrence, distant metastasis, but nodal metastasis are less. That equivalent in melanoma is your desmoplastic melanoma, where you have a high PNI, high grade lesion, high local recurrence, so less chance of nodal metastasis. So because despite having PNI, it's the less chance of having nodal metastasis, commonly present in the head and neck areas. Now, because of this less nodal metastasis, there are authorities who say that you can avoid even a sort of like an SLNB, but currently most authorities have not clarified that. So in your treatment, what will you do? You will do a wide excision and you will do a sentinel lymph node. You will have to address the nodes even in a desmoplastic melanoma. Why they said you don't need to do an SLNB? Because if the lymphatic pathways and everything is destroyed, there is a very low chance of nodal metastasis because of the desmoplasia. But in practice, whenever you have it, you still do wide excision with the what you can say as the sentinel lymph node or a nodal dissection. Now, when do you call it as a pure desmoplastic type? If more than 90% of the tumor is desmoplastic, only then you will call it as a pure desmoplastic type. And this is the characteristic feature, the prominent stromal fibrosis which is going to be present. That is going to be the characteristic feature of this particular type of melanoma. So correct M stage in a melanoma. No. Now there are few cancers for which you have the subclassification as M1, A, B, C, etc. So melanoma is one such type. So the one with the most favorable subtype is going to be your distant skin, soft tissue, and your distant nodes. So local nodes will come under, of course, your N plus category. So distant skin, distant soft tissue, and distant nodes will come under M1A. The other types, then you have your M1C, which is your CNS metastasis. Sorry, non-CNS metastasis is M1C. M1D is the highest type, which will be your CNS metastasis. Then M1B is what? Lung metastasis. That is known as your M1B. Okay, so skin and nodes, that is M1A. Lung is M1B. M1D is your CNS. That is the worst prognosis. And then you have the other visceral metastasis, which will be M1C. Okay, so M1A is skin, or let's come down from top. The brain is the most common one. That is, I mean, most dangerous one, M1D. Then any other visceral metastasis. Lung is M1B. And then the least important are the other cutaneous skin and your distant nodes and all that. So that is how your M stages classification. And in this, you will add on LDH being high or normal. If the LDH is high, then it is put it as 1. So you will put it as M1A1. If you put it as, then you mean that the LDH is elevated also. So within the suffixes, so you will put it as M1B, and then in the bracket, if you put it as 1, so that means that the LDH is elevated. Suppose this is 0, then it means that the LDH is normal. So this is the way it will be notated for your M1 in your melanomas. Now, this classification of melanomas, of course, the TNM staging is very important. Multiple times it is asked. So just remember, very thin, thin melanoma, intermediate, and thick melanomas. Very clear. So thin melanoma is anything less than or equal to 1 millimeter. Okay, so less than or equal to 1 millimeter. And then thick melanomas are going to be more than 4 millimeters. That is your T4. Okay, in between what do you have? You have 1, then you have 1 to less than 2, 2 to less than 4. These will be T2 and T3. So T2, T3, T4 is very clear. So anything, basically between 1 to 2, 2 to 3, 2 to 4, and then more than 4. That is going to be your T2, T3, and your T4. So T4 is your thick melanoma. T2 and T3 are your intermediate thickness melanomas. T1, again, you have your, you know, thin melanomas, basically anything which is less than or equal to 1 millimeter. Remember, it's not 1 centimeter, it's 1 millimeter of invasion. In this, again, you have a subclassification as less than or equal to less than 8.8 mm. Okay, less than 0.8 mm. Remember, in your Breslow's, it used to come as 0.75. Okay, similar to that. So instead of 0.75, we are using here as 0.8. So less than 0.8, more than or equal to 0.8. So 0.8 to 1 is considered to be T1B, or less than that with the presence of ulceration. Now, the best prognosis is for a T1A type, and this is the only one where you will not consider doing an SLNV. So, any melanoma less than 0.8 millimeter invasion and there is no ulceration, so then you will not do an SLNV. All other melanomas need an SLNV. So, A and B is with and without ulceration. The suffix T1A, T1B, like that, when you say, that is with and without ulceration. And additionally, in T1A, you have the size cutoff. Depth should be less than or less than 0.8 millimeter. If the depth of invasion of melanoma is 0.8, that is your criteria. So the end stage, if you look at it, remember you have in all this N1, 2, 3, all of this, the first one is with regard to SLNB, the second one is clinical, and the third one is to do with satellite nodules. So this is the gross classification. So now come the numbers. N1 is 1, N2 is 2 to 3, and more than that is going to be N3. Okay, so one node is N1, 2 to 3 nodes is N2, and more than 4 or more nodes is considered to be N3, right? So now you have the numbers. Now, as I said, A, B, C, the notations are based on what you can call as your SLNV nodes. Then you have your clinically detected nodes, and third one is your satellite lesion. So this is how, this is the gross notation. Now you take N1. N1 is what? There is only a single nodal invasion which is present. So what is that? A, I said, is SLNV. So one node which is detected by SLNV is N1A, and one node which is clinically detected is N1B. And suppose you have a satellite lesion in transit, or a satellite lesion or microsatellite without the presence of nodes, because if it is with nodes, then it will go to N2, right? So when it is without the nodes which is present, then it is N1C. So clear now? SLNV, clinical, and satellite nodule. So N1 ABC is now come. So what is N2? N2 is 2 to 3 nodes. So what is there then? N1A becomes 2 to 3 nodes which are detected by SLNV. As I already said, it is SLNV. So 2 to 3 nodes which are detected by SLNV. And what about this one? N2B is clinically detected, right? So 2 to 3 nodes, at least one should be clinically detected. Very clear. One node is clinically detected. And the N2C is something where you have one which is an SLNV, and then or a clinical node with this. So basically a combination of one node, either SLNV or by clinical detection, you have one node plus a in transit or a satellite nodule is there. Both of these come together, then you call it as N2C. Then you go to N3. N3 is what? SLNV. N3A is SLNV. 4 or more central lymph nodes are positive. And again, N3B is going to be 4 or more nodes positive. At least one is clinically detected. At least one is clinically detected. And here it is 2 or more nodes, clinical or SLNV, with an in-transit lesion. Very clear. Okay, so that is how you group it as. Okay, now I think it will be clear. N1, N2, N3. N1 is one node, N2 is 2 to 3 nodes, N3 is going to be 4 or more nodes. So N1 and ABC is what? A is SLNV, B is clinical, C is in transit. So 1, N1A. So N1 I said is one node. So A means it is only by SLNV. N1B is only one node, which is clinical. And N1C is a satellite nodule without any nodes, right? So N2 is 2 to 3 nodes. So N2A is 2 to 3 nodes, which are detected only by SLNV. N2B is what? At least one clinical node with one or more additional nodes which are detected by your SLNB. Then you have your N2C, which is a combination of one node which can be found either by SLNB or clinical, and with your in-transit. So in-transit is present plus one more node, either clinical or SLNB is present. Then you have your N3, which is 4 or more nodes. So A is SLNB, so 4 SLNBs. B is one node clinically detected and multiple other nodes, like up to 4 or more nodes is present, of which one is clinical. So that is your N2B. And presence of two nodes, either clinical or SLNB. Let's say there is one clinical node or two clinical nodes and two SLNB nodes, or two clinical nodes or two SLNB nodes, along with in-transit metastasis is present, then you call it as an N3 lesion. I think that should be clear. Can I have an answer in the chat box as to whether this is clear? This concept of N in nodes, because that can come as a question. So can you just put up in the chat box whether this is clear or you want me to repeat? The T and the N staging are there. So N1 is 1, N2 is 2 to 3, N3 is going to be 4 or more. And so A is SLNB, B is clinical, C is going to be your combination of satellite and this one, or only the satellite lesions. Okay, so that is how. So try to subclassify like this, and remember again, thin and thick melanomas are also the same way we'll have to remember. Now, IHC markers, this question has come quite a number of times. So the most specific marker, remember the question, the most specific IHC marker for a melanoma is S100, HMB45, melan-A, or melanin. So this is a question that has come multiple times. Remember, the most sensitive marker is S100. The most specific marker is melan-A or MART1. Okay, the most sensitive is your S100. The most specific marker, the answer here for specific is going to be your melan-A or your MART1. Okay, so if you look at the IHCs for melanoma, melan-A or MART1 is the most specific. Previously, they considered HMB45, but now it is melan-A or MART1, very clear. Name is melanoma, most specific is melan-A or MART1. Most sensitive is S100. We saw the ascended staining even to differentiate between Paget's and melanoma. We were discussing, you remember? So at the time when we were discussing Paget's disease, we were discussing this also. So HMB45, on the other hand, can distinguish from a benign nevus to a melanoma. HMB45 is likely positive in a melanoma, but never in a benign nevus. So that differentiation can be done with your HMB45, which will be clearly showing the difference. Okay. Now, what is the thickness of excision for a melanoma? What is the, width of excision for a melanoma? Now, overall, commonly the thing will be, whenever you have it, any melanoma which is not a thin melanoma, it is a 2 centimeter margin. Okay, so except for T1 melanomas, the margin, anything greater than T1 is there, then the margin should be minimum 2 centimeters. Okay, so the margin should be minimum 2 centimeters. Now, if you have a thin melanoma, then the margin can be 1 centimeter. Okay, so when it is basically, if you look at, let's go back here. With the annotations, when we have it here. So when you have a thin melanoma, go it for 1 centimeter margin. Any of this intermediate 1 to 2 millimeter, they sometimes mention as 1 to 2 centimeters. If that is given in the option, then you choose 1 to 2. But otherwise, generally, overall, the option is 2 centimeters. Whenever you have any melanoma greater than T1. So T1 thin melanoma will be 1 centimeter. So only for your thin melanoma, the answer will be 1 centimeter. So thin melanoma, whenever you have the thing is 1 centimeter, anything more than that, just straight away you can mark it as 2 centimeter. And in situ, melanoma in situ, generally when you have half a centimeter, that is the margin that is recommended. Okay, so there is no evidence that margins more than 2 centimeters are beneficial. So there were multiple studies that compared, but the recurrence rates between margins of 2 and 3 are not very, it's generally what they say is the larger the margin, the lesser the local recurrence. But other than that, the overall survival does not change. So overall, the 2 centimeter margin can be considered. So I will put it this way. Suppose you have a place where you can resect a melanoma with some greater margins up to 3 centimeters, please go ahead without causing morbidity. But if there is going to be morbidity, then it is better to go for a 2 centimeter margin and stop with that. So, okay. So in general, for a small lesion less than 1 centimeter, then you can, as I already mentioned, you can do a 1 to 3 millimeter margin till the subcutaneous fat. You have to excise small lesions. For larger lesions, go for a punch biopsy through the thickest part of the lesion. Again, shave biopsy is usually recommended for squamous cell basal cell only, not for melanomas. In situ is what we consider to be confined to the dermoepidermal junction without breaching it. So the melanoma cells will involve the entire epidermis, but they will not breach the dermoepidermal junction. So here you can do a 5 millimeter margin of excision. So these are the margins for a melanoma, and this is the IHC. The most sensitive, again, I will tell you, is S100. This has come as a question, and again, melan A bar mart 1 has also come as a question, which is the most specific. And again, the margins for melanomas have come 2-3 times as a question. Now, I already asked this, where is the sort of like, the most important prognostic factor for a melanoma that has come as a question is the nodal status, is the N status. If they ask us which is the most important prognostic factor overall without saying anything, then the answer is N. Suppose they mention as in a node negative patient, then that is where you will have the thickness that will come into play. Okay, so thickness will come into play only there. So now let's go on to indications for SLNB are all except. So where will you not do a SLNB? So I think this is a very clear answer here. So nodular melanoma, 3 millimeter thickness. So what is this? This will come under your T3 lesion. Okay, so this is going to be your T3 lesion. Then you have your superficial melanoma, 0.7 millimeter thick with ulceration. So this will come under T1B. Then you have your acral lentiginous melanoma with 0.7 millimeter thickness with no mitosis. This is again another factor which will be taken. So this is what will be considered to be your T1A melanoma, and this is probably the only melanoma where you don't need to do a sentinel lymph node. Desmoplastic melanoma, 4 millimeter in thickness, but irrespective of thickness, basically anything which is T1A, you can avoid an SLNB. All other cases you have to plan for a SLNB. So melanomas less than 0.8 and no ulceration, no mitosis, they can be observed without an SLNB as the risk of nodal metastasis is less than 5%. Desmoplastic, as I said, comes under the gray zone. Usually they are associated with low risk of metastasis, but standard of care is still to do an SLNB. And any melanoma which is more than 1 millimeter or the presence of ulceration is there, then you have to definitely plan for an SLNB. There is no question with regard to that. So the most important prognostic factor is going to be the nodal involvement as far as melanoma, and Breslow's thickness is the most important factor in the absence of node. So in stage 1 melanoma, the most important prognostic factor is your Breslow's thickness. Here you can see clearly, the nodal disease, the lymph nodes with the architecture and the melanoma cells which are infiltrating it. So any lesion which is okay, sorry about that. So any lesion which is going to be more than T1, more than 1 millimeter depth needs a nodal assessment by a SLNB as the preferred option. Thin melanomas with ulceration and mitosis also are indications. So any ulceration, presence of any mitosis, and presence of thickness more than 1 millimeter, all these are indications for a melanoma. So the essential trial that were done were the trials by Morton et al., where they used technetium, sulfur colloid, 0.5 millicurie or blue dye with 1 to 5 ml, and wheel 5 millimeter away from the melanoma within the margins of excision. It's a dermal injection. So this is the melanoma sentinel lymphadenectomy trial 1. So the MSLT trial 1 was the first trial that proved the benefit of your sentinel lymph node melanoma. So what they do is they will identify, and this is the node which is getting identified. You can see this is probably the femoral vein that is there, and you can see that the melanoma is going to be present here. And the sentinel lymph node is present here. You can see the blue node which is beautifully identified. And what is the MSLT2 trial? So the MSLT2 trial was one trial which kind of like, or the German DCOG studies, which were de-escalation strategies. What they said is there is no need for doing a completion lymph node dissection after an SLNB, because what they found is in almost 90% plus of cases, the only node which was positive was the sentinel lymph node. So in a patient with a node negative disease, again, remember this is all in clinically node negative, clinically, radiologically node negative disease. Just like in breast, when the nodes are clinically and radiologically node negative, that is where you can plan for an SLNB. Node positive, straight away you have to go for a nodal dissection. There is no question. So in a clinically and radiologically node negative patient is when you will plan for an SLNB. In many of these cases, you will find that SLNB node is the only node which is positive. There are some differences with regard to nodal dissection and SLNB techniques as far as a melanoma is concerned. So remember, in axilla, for example, you have to do a level 1 to 3 nodal clearance. It is not just level 1 and 2 like we described in breast. 1 to 3 we have to do for axilla. And inguinal, you will have to do a superficial inguinal dissection pelvic nodal dissection is done whenever there is a multiple inguinal nodes or the deep node, which is usually the clockwise node, is positive, appears significant. Then you have to do a deep pelvic lymph node, deep and pelvic lymph node dissection have to be done. In cervical lymph node dissection, at least an MRND type 3 needs to be done, and you have to address the parotid nodes as well. Additionally, you have to take out the parotid nodes here to make sure that all the nodes are cleared. And remember, whenever you're doing an SLNB in a melanoma, the main technique that will be followed is the technetium sulfur technique. The technetium sulfur technique needs to be done, and you have to do a preoperative lymphoscintigraphy. Why do we need to do this lymphoscintigraphy? Because you have this nodes called as the intercalary nodes or the interval nodes. You have something called as the intercalary or the interval nodes. Like for example, in the breast, if you do, it is only the axillary nodes that will come. But for you, if you do it in the hand or in the fingertip or somewhere, it can be epitrochlear nodes, which can be positive. It can be any of the intransit nodes. And these need to be identified because they may be the only positive nodes, as I mentioned, in almost 85% of cases. So always in patients with a melanoma, you need to do a sentinel lymph node biopsy. In SLNB in melanoma, there are some principles. Radiocolloid has to be used. You need to do a preoperative lymphoscintigraphy. These two are mandatory. And there is no frozen section which is done in a melanoma. The lymphadenectomy, if at all you complete it, is going to be done at a later stage. It's always an ultra staging, so there is no frozen section of the node in a melanoma. So you do technique with radiocolloid, you do preoperative lymphoscintigraphy always. It is not mandatory in breast and other locations, but here it is mandatory to remove and do the surgery. So you have to do a removal of the nodes. You have to do the by lymphoscintigraphy has to be done. You have to use the radiocolloid. Because only in radiocolloid you can do a lymphoscintigraphy and identify the location of the nodes preoperatively by imaging. ICG is now coming up that way to some extent because you can find some intercalary nodes, but it is not at the standard of care. So today's world, it is still radiocolloid which you have to do. You have to identify it, and you have to identify the node as well. So thin melanoma, intermediate thickness, and thick melanoma. So better predictor of prognosis is your Breslow's thickness rather than your Clark study. So it is the top of the granular cell layer to the deepest point of melanoma. That is how you measure the thickness. So this is the SLNB technique. So you can see that there is an axillary node here with the injection site here. And then you have the anterior and the posterior views again, which shows the same thing. Submandibular lymph nodes in a head and neck melanoma with the primary injection site here. And this is the wheel and flat technique. You are doing it, and you are identifying an inguinal node here. As you can see in umbilicus, periumbilical, you have injected and you're finding the node in the right inguinal, because they can go to both the sides. They can go to the axilla as well. So here you're identifying it in the right inguinal area. So this is the reason why you always need a radionucleotide assay, and you also need radionucleotide study, and you also need to give a preoperative lymphoscintigraphy. And the most important factor of survivors is going to be the nodal disease. The most important prognostic factors in the absence of nodal disease is going to be your Breslow's thickness as the criteria. Now, this definition, I'm sure that most of you will know. Satellite nodules indicates less than or equal to 2 centimeters from the primary, and in-transit lesions are those that are more than 2 centimeter. Now, remember that in-transit are usually towards the drainage area of the limb, but you can get your in-transit lesions in the distal part also. Suppose in a foot you have somewhere near the ankle, it can be even distally present as the as an in-transit lesion, but sometimes it can be away from the primary also. Usually though, it will be in the direction of your lymphatics, and the differentiation cutoff is 2 centimeters. Less than 2 and more than 2 centimeters, we call it as satellite and your in-transit lesions. Now, what are the adjuvant therapies that you are using? Okay, so surgery, you are clear. 1 millimeter depth up to, let us T1, 1 centimeter. Anything more than that, it is going to be 2 to 3 centimeters. 2 centimeters usually is the minimum wide excision cutoff that you have to do. Nodal management, clinically node positive, node dissection. Clinically and radiologically node negative, then you will do a sentinel lymph node biopsy. You will inject, and then you will go ahead and you will do the sentinel lymph node biopsy as the technique of management. Okay. Now, what are the other additional therapies based on the stage that you have? So now you have additional immunotherapy. So stage 3, whenever you have node positive disease, then you will go for dabrafenib and trametinib. So this is the combination which will be used. So dabrafenib, as I already mentioned in the class, BRAF inhibitor. Trametinib is an MEK inhibitor. So you have your dabrafenib, you also have vemurafenib and your pobimtinib as a combination. So that is another combination. So a BRAF inhibitor with an MEK inhibitor for 1 year. That is one category where you have one thing which is used for your stage 3. And adjuvant immunotherapy has now come in based on the ipilimumab. Now, this ipilimumab Anti-CTLA4 has come multiple times in the exams. I'm sure there is a easy sitter for all of you. So anti-CTLA4 antibody, the drug is known as ipilimumab. So that is the adjuvant immunotherapy agent, one of the first immunotherapy agents to come into practice here. Then you can also use pembrolizumab in the management of a stage 3 melanoma. So today, before, we used to have only surgery as the option for a melanoma. There was no other treatment which was available for a melanoma. And nowadays you have for stage 3, you will use BRAF inhibitors with MEK inhibitors. You also have immunotherapy as the treatment option. Is there a role for adjuvant radiation? Radiation used to be considered as something which is, melanomas are radio insensitive, but that was still the TROG study came, the Trans-Tasmanian Radiation Oncology Group studies. So when you take it, so head and neck, basically any parotid node which is involved, that is significant. Cervical nodes is two or more cervical and axillary. So parotid, even one node is significant. In the neck and axilla, it is two or more. In the inguinal regions, it is three or more. So all these are considered to be high risk features. And then presence of extranodal extension. Whenever you have the matted nodes or invasion of extranodal extension, which is all found out, so that is a high risk node. And then diameter of the largest node more than 4 centimeters overall and 3 centimeters for cervical nodes. We all know that 3 is the cutoff in cervical. We were discussing the end staging of head and neck in our class, so that is again a high risk thing. So the first therapy, as I already mentioned, I was discussing regarding the immunotherapy, right? If you guys remember, so then that is the high dose interferon alpha 2b. That was the first therapy which was used. So now, of course, it is all immunotherapy with pembrolizumab, with nivolumab, with agents that are used are pembrolizumab, nivolumab, ipilimumab. All these are the agents which are used in type 3. Commonly, we use immunotherapy. No, it is not even the dabrafenib and vemurafenib or trametinib and cobimetinib. It is usually the adjuvant immunotherapy which will be used in stage 3. Adjuvant RT, though it is there, and these are the criteria they may ask you, but it's less commonly used, even though it is clearly there by the study because of the morbidity of a nodal dissection followed by radiation. So advanced metastatic melanomas, what is the management of a stage 4 melanoma? As I already mentioned, it is going to be dabrafenib, vemurafenib as BRAF inhibitors, and trametinib and other drug called as cobimetinib, C-O-B-I, cobim, C-O-M-B-I-M-E. I'm sorry, I'm just writing it with I don't have a pen with me. So C-O-B-I-M, this is M. Okay, cobimetinib. So cobimetinib, metinib is the same. So C-O-B-I, cobimetinib. So that is another MEK inhibitor which can be used. So dabrafenib with trametinib or vemurafenib with comitinib are the combinations that are used. And immunotherapy, as I already mentioned, anti-CTLA4 is ipilimumab, and then you have your pembro and limozumab, which are the anti-PD-1 agents. c-KIT inhibition is used whenever you have c-KIT positive melanomas, which happen very rarely. Now, you get these in-transit lesions and satellite nodules, so you have other techniques which can be used. So for the in-transit, there is one viral vector that came as a question, which is an oncolytic virus, Talimogene laherpa effect. This is an oncolytic virus. This is a gene therapy. This is your gene therapy encoded with GM-CSF that is found to be highly effective. So other than that, you have your PV10, you have BCG, interleukins, interferons. All these have been used, but the likely things they will ask you are the PV10 and then your Talimogene laherpa effect, which is your basically your herpes virus with an oncolytic herpes virus that will be encoded with your GM-CSF that accepts it. And remember, in patients with limited metastasis in the brain, in the lung, in the bone, all these areas, you can use your metastasectomy. We were discussing, oligometastasis. It is not a defined concept, but less than less than 5 metastasis, less than 3 organs is defined in breast. In melanomas, we don't have a defined number, but overall limited metastasis, when you have, that is an indication for trying and doing a metastasectomy. Of course, you give immunotherapy first, then you go for this kind of treatment. And of course, this is your isolated limb infusion and your isolated limb perfusion, hyperthermic isolated limb perfusion. So what is the main difference between limb perfusion and limb infusion? So you basically apply a tourniquet completely, kind of isolating the blood supply. Don't allow any normal blood flow with a pneumatic tourniquet. So that is your kind of completely stop the blood supply. That is what you use in your isolated limb perfusion. In your infusion, the pump oxygenation is allowed, which is not allowed in your isolated limb perfusion. So those are the differences between ILP and this one. There is a kind of the normal blood flow is allowed inside in your infusion, whereas absolutely no normal blood flow is allowed in case of a isolated limb perfusion. So that is the major difference between the two. So isolated limb perfusion and isolated limb infusion. Preferred is usually isolated limb infusion because there are less toxicity, though more efficacious will be the isolated limb perfusion is more efficacious. Infusion is used because there is less chance of necrosis of all the tissues here. The agents which are used are melphalan and TNF alpha. Both of these are used. TNF alpha and melphalan, both of these are used in the isolated limb perfusion and infusion of the lower extremities. So going on to a bit of non-melanoma skin cancer. So this is my friends is all about the management of melanomas. So with regard to sunlight and skin malignancies, we already saw SCC related to, which is the correct statement. SCC is intense intermittent. That is wrong. Chronic to BCC is also wrong. Melanoma is intense intermittent. This is the correct option. Recreational is not related to SCC is also a wrong option. So as we saw, so chronic sun exposure, actinic keratosis with SCC, melanoma and BCC with intense and intermittent exposure. UEB is the most common. UVC is the most dangerous. 20% are non-melanoma skin cancers, and UVB radiation induces P53 mutation, and chronic sun exposure is important. So chronic scars like a Marjolin ulcer, burns, osteomyelitis. This is an osteomyelitic scar in a chronic wound. So this kind of picture can be given. All these will have, important. There is a higher risk of distant metastasis. Nodal metastasis are less common. It will happen once the tumor extends beyond this, because this area, the lymphatics will be destroyed. So once it crosses the edge of the wound, that is the area where you will have your nodal metastasis. But before that, likely it will cause a distant metastasis more likely. And immunosuppression, especially after transplant, is more common. So if you look at it overall, the most common cancer is BCC, but there is a 10-fold increase in, if you take up organ transplant and immunosuppression, there is a 65-fold increase in SCC. So in transplant, which is the most common skin malignancy, the answer is going to be your SCC. It is 65 times more common. And this is, of course, this has come as a question, the classical keratin pearl. You can see that there is nothing there except the keratin layers, like an onion peel appearance inside, with, of course, the surrounding, squamous cell. You can see that the malignant squamous cells are there with the, this central keratin pearl. Very classical, usually in a well-differentiated squamous cell carcinoma is where you will find it. Well-differentiated squamous cell carcinoma. Of course, exposure to arsenic. Arsenical dermatitis will cause multifocal skin involvement. I've had one patient, poor lady, multiple times we had to operate. Initially, she had a lesion near the inguinal region. We resected that. Then she came back with a scalp lesion. We resected that. She had multiple other small lesions, all of which were slowly turning. So that was basically arsenic exposure in childhood. So that happens in parts of Northeast, in interior parts of Andhra, I believe it happens, some places of Tamil Nadu. So these are all areas that are prone for having this arsenic exposure, which will lead on to multiple cutaneous carcinomas developing. Of course, albinism, actinic keratosis, xeroderma, all these are the precursor lesions that will be there. And BRAF inhibitors, this is an important factor. Though BRAF inhibitors are curative in your melanomas, they can cause squamous cell carcinoma. They can cause squamous cell carcinoma. And as I already mentioned, the cutaneous HPV5 is important. 16 is also there, but the most important, if you ask in exams, will be your HPV5. We already had a discussion on HPV and your skin lesions. So HPV5 is the most important. So what is this lesion? So this is your classical keratoacanthoma. You can see the raised ulcerated lesion with a central ulcerated crater. So this is your keratoacanthoma, which is a self-healing BCC, self-healing SCC, as it is called, as the central keratin plug. So the lesions, as we already discussed, actinic keratosis with a 10 to 20% risk of malignancy, keratin horn with around a 10% increased risk of SCC, keratoacanthoma, which is a self-healing SCC. This is a question again, how will you manage though? You have to do an excision to rule out a squamous cell carcinoma, invasive type. So management is still surgery, same thing as you will do for other things. So it is not observation, though it is considered to be self-healing, you will always excite this. And what is in situ? You have this, various names. Overall, it's called as Bowen's disease and erythroplasia of Curie in the glands or in the vulva. So this what we have is your actinic keratosis lesions or your Bowen's disease here. This is your sebaceous horn that you have, and this is your keratoacanthoma. So invasive SCC classically will have the everted edges and the classical keratin pearls, borders grading system, and CK1 and 10 IHCs can be used. High risk areas are the dorsal hand, the lips, and the ears. So the extremities, the lips and the ears, all these are considered to be the high risk areas. So regarding anatomical thing, this has come as a question at multiple times. I'm not going to discuss this before discussing what is actually the high risk types and everything. So the high risk areas. What is the high risk area? So I remember it as the mask of Zorro. So the mask of Zorro is what? One is the eyes in this area. So it is going to be the orbital, periorbital, the temple area, the eyelids, the eyes, and the temporal post-auricular, auricular, post-auricular areas. All of this is going to come. Then the mask, you remember an N95 mask. What is the N95 mask? It's going to be like this. So the N95 mask is the central area of the face, and it is going to come into the nose, chin, and mandible. So remember an N95 mask with the mask of Zorro. Very clear. I'm sure all of you would have seen the mask of Zorro. So just you will have this kind of mask with this kind of thing. So the that is basically your central area of the face, which is the N95 area, the chin, starting from here, the chin, the mandible, the perioral areas, the perinasal and the nasal areas. All this will come under the N95, and the strip that you have here, which is going to be the eyes, the eyelids, the temporal, and the post-auricular areas. That is the high risk area, which is the mask area. Other than that, hands and feet, and then your genitalia. All these are high risk. Now, what else is there? Then you have the pretibial areas, the rest of the head and neck. So you have the head and neck, you have the neck, you have the scalp, you have the this area, the forehead, and then you have the cheeks. So all these, the rest of the head and neck is again considered to be a medium risk area along with your pretibial. Okay. So this strip mask area, the N95 area is high risk. The rest of the head and neck is considered to be medium risk along with your pretibial. Hands and feet are high risk, genitalia is high risk. All other areas are considered to be area L. So you have your area H, you have your area M, and you have your area low. Are you clear on this? Are you able to understand this? The N95 with the central strip mask, with the eye strip mask. Are you clear on this? Please put up a message in the chat box. Okay, so the remember simply N95, all of you will remember, and the strip mask area. So post-auricular, eyes in this areas will come. The rest of the head and neck will come as your medium risk area. Of course, hands and feet, any extremities are high risk, including the genitalia. And then the pretibial will come as a medium risk area. Okay, so the pretibial area will come as a medium risk area. Okay, so this is about the central area H and area M, you understand. Anything else is going to be kind of like area L. Okay, so in your high risk lesions, anything in area H, any high risk area is high risk. Obviously, that is why it is called as high risk. In M, the cutoff is 1 centimeter. In a M, that is the medium risk area, that is going to be 10 millimeter, that is 1 centimeter. All other things, it is 2 centimeters. Remember, we already talked about the high risk areas. More than 2 centimeters is always a high risk. Anywhere the size is more than 2 centimeters, high risk. Anything in the hands, feet, genitalia, all these areas, when it is there, it is significance. And head and neck areas in the mask areas is significant. And other than that, in the rest of the area, more than 1 centimeter is also significant. So that is the criteria. And the depth is Clark's level of 4 and 5. So it is going on to the reticular dermis and to the subcutaneous area, that is considered to be a high risk. And the depth of 2 millimeter or more is also considered to be high risk. So this is how you classify the high risk and your low risk areas. So then you have depth, as I already mentioned, less than 2, there are no metastasis. More than 6 cm, there is a 15% risk of metastasis, usually to the nodes. LVI and PNI will make it a higher, broader grade, and size more than 2 centimeters. These are all criteria which in various. So 2 centimeter, 2 millimeter depth, Clark's level 4 and 5, all these you can take it. So 2 centimeter, 2 millimeter, and Clark's level 4 and 5. So that is the criteria that you can remember. More than 2 centimeters or more than 2 millimeter depth, and then the mask areas of the face, the facial, the eye band area of high risk. So all these are considered to be the high risk area. Presence of LVI, presence of PNI, presence of immunosuppression, all these make it a high risk lesion. Now surgery, what do you do in case of a low risk lesion? So what is given is basically in Sebastian they have given as 5 mm. 1 centimeter is very clear. Whenever there is any high risk, it is 1 centimeter. Everybody agrees the margin should be 1 centimeter. For a low risk, what is the margin? I will prefer to go with 4 millimeter. Though it is not clearly mentioned in other guidelines and stuff like that. So 4 millimeter generally. So when they mention it along with size, maybe as less than 2 centimeters, then go with 4. Okay. Otherwise, probably go with 5. Low risk and high risk stars, you can probably go with 5 and 10. So it is a very difficult thing. In your exams, I'm not sure what you should mark, whether you should go with that 4 or 5, but I will remember it like this. So mostly we should mark it as 4. If 4 is given as an option, mark 4 as the option. for any low risk BCC and squamous cell carcinoma. Anything where it is mentioned as low risk with 4, then you give it as 4 millimeter as margins. Otherwise, you mark it as 5. If 4 is not given, then you go for 5. Probably that is what I would do. It's not very clear because two books have given differently. So I'm not sure what to do. NCCN also is not very clear, but I remember in previous versions of NCCN, it used to be 4 millimeter. So that is why I'm giving this option of 4. Though Sebastian gives you 5, still I'm sticking to 4 as the option. And there is another thing which is mentioned in marks as a 6 millimeter margin for high risk lesion. So again, it gets more confusing. So for exams, I will say low risk. If 4 millimeter is given as an option, go for 4 mm. Anything high risk, mark it as 1 centimeter. Very clear. So low risk 4 millimeter, high risk is 1 centimeter. That is what I would take it. And this is of course the Bowen's disease and the erythroplasia. This is how the Bowen's disease will look like. They may give this clinical picture, and this has been asked. This erythroplasia of Curie has been asked a couple of times. So yeah. So this is again the most common cancer in the world registries is. You want to put up the answer in the checkbox, which is the most common cancer in the world registries today. World cancer registries. Okay, I've got one answer so far. The rest of you are sleeping. I see there are 25 plus other guys. Breast, lung. Breast is not there in the options, boss. That's why I didn't give it. I didn't want to confuse you. Okay, so all of you are still awake. The answer is, of course, lung. Lung is the most common cancer worldwide today. Okay, so remember in 2020, the data changed. 2018, it was lung. 2020, it came as breast, and then again, it is now gone back to lung. Actually, the latest one, as in terms of this one, I think it's in 2022 or something, the Globocan. That one gives lung as the most common. See, breast and lung are pretty close to each other. It's like few thousands of difference which are there. So overall, the most common cancers are lung and breast that happen. So currently it is still lung. In the books also it is still given as lung. So we'll go with lung as the option. And then the one which is not reported is of course your BCC. Suppose they just ask which is the most common cancer, then if BCC is given, choose BCC as the option. But here it's in registries, it's mentioned. So the answer is going to be your lung. So 2018 was breast, lung. 2020 was breast is greater than lung, and 22 again it has changed. 22 to 23 when it came again, lung has overtaken. Okay, so the most common malignancy overall is BCC. When you take overall, what is the most common? It's BCC. Upper lip, whenever you have a tumor, answer is BCC. And whenever they say eyelid tumor malignancy, then it is BCC. Margins 4 millimeter for low risk and 10 mm for high risk. Just remember that as the option. That should be good enough. And second primary, usually BCC will happen in about 40% of cases, usually within 3 years of the initial primary. Now, yeah, UV radiation, all this we define. This is the peripheral palisading. I told we had one other picture at the end. So this is the classical peripheral palisading. You can see that the central areas are having the malignant cells, and periphery you can see like a fence which is lining it completely. So this peripheral palisading is the very classical feature with the rolled and the edges. So this kind of question can come. Multiple questions have come. As I said, they ask the image-based question. So peripheral palisading is a very classical question that can come. And it arises from there is no predefined precursor lesion which is going to be present. And this is another pictorial representation of the peripheral palisading for you to understand with the peritumoral clefting. So these are the kind of cells that are going to be present arising from the epidermis and going on to there. So these are the classical features that you are going to have. And nodular BCC is the most common type, and the hedgehog signaling pathway mutations are present. When you talk about the pathway, the patch protein is one we saw, and the hedgehog signaling pathway. So you have two drugs which are available, sonidegib and vismodegib. So these are two drugs, sonidegib. Degib is basically based on the hedgehog pathway. That is why it is named like that, sonidegib and vismodegib. So morphiform BCC, this question we already had. It is the type 4 collagenase which will be secreted, spreading edges due to the type 4 collagenase. Most aggressive variant, most common variant is of course the nodular BCC. So superficial spreading, infiltrative, all these are the other types. Now there is one special type which is known as the morphiform type. Sorry, one special type called as the micronodular type, which is more aggressive. It is sort of like a mixture between the morphiform and the nodular type, which is known as the micronodular type, which is an aggressive growth pattern, and that is considered to be very, very significant. Okay, so this is what we discussed already. So low risk, high risk. So other features which are there are the incidence, whether it's primary or recurrent, and then presence and absence of immunosuppression, exposure to radiation, All these are significant. And then presence of ulcer, neural and vascular symptoms, vascular invasion, neurological symptoms. All these are considered to be low risk and high risk features which are present. This is of course an old version of NCCN. Now most of it is taken off, but currently still some of these things, this 2 centimeters, this forehead and neck being 10 millimeter, that is what we discussed in the M, H and the L areas of the face. That is what we are having here in the same tabular column. So that is good enough for you. So the management is 5 mm, or I will say it is 4 mm margins. For Sebastian it's given 5, but generally I'll go for 4 mm margins and 1 centimeter in a high risk lesion. So most micrographic surgery in vital areas. Field therapies can be done. RT, except in scar areas, RT is contraindicated because it can cause a very aggressive form and rapid spreading and metastasis. So in scars, it is contraindicated. So cryotherapy, PDT, CO2 laser, electrodesiccation and curettage, 5-FU and imiquimod are used in pre-malignant lesions like Bowen's and acne keratosis. So 5-FU application and imiquimod are well-known agents in this one. And advanced pathway is, as I said, advanced disease, you will use vismodegib. Degib is basically your sonic hedgehog inhibitor. So this is known as your vismodegib and sonidegib. That is the other drug which is available. Sony, SONI. So sonic hedgehog pathway, it is called as. So sonidegib and vismodegib. Sonidegib and vismodegib, both are the drugs which are available in advanced HCC. Word or two about other rarer tumors here. What is Merkel cell carcinoma? So Merkel cell carcinoma, you can simply remember as a congener of your melanoma. It will look very similar to melanoma. The treatment, the management, everything is pretty much similar. You will find those small blue round cells on histology. Okay. So the specific drug which is used in management of Merkel cell carcinoma is something called as avelumab. Among the immunotherapy agents, avelumab is a specific drug which is used only in your Merkel cell carcinoma. Avelumab, do not confuse with atezolizumab. This is your avelumab, AVE lumab. Avelumab, that is the drug which will be used in your Merkel cell carcinoma. It is caused by the Merkel cell carcinoma polyoma virus. It's a virus derived mutation, and you will find that it has got CK20 positive. And then it is a neuroendocrine carcinoma. Basically, it's a small blue round cell tumor, neuroendocrine carcinoma, CK720, like that we talk, no, IHC. So this one will have the CK20, which is positive. And SLNB is used in all T stages. Same thing, 1 to 2 centimeter wide margins, along with SLNB, role for adjuvant RT in select cases. This is all like pretty similar. Basically, it's a like a melanoma of the soft parts. It is a soft tissue tumor. More of a nodular lesion will be found, not pigmented. It is a kind of like a nodular lesion that will be used. So that is the characteristic thing. So the avelumab is the specific drug which will be used in the management of these particular patients. And what do we have here? We have the extramammary Paget's disease. So this can be a clinical picture. The same picture histopathologically I'm using here, but this is the extramammary. You can see that it's a perianal lesion that has developed. This is how the ulcerated dry straw lesions will be there, and you can see the pagetoid cells arising from the Malpighian layer going up, large clear PS positive cells arising from the Malpighian or the basal layer. All that is what we already discussed, and there is an underlying malignancy in 40% of cases. So whenever you have a lesion like this, you have to look for either perianal or perivulvar. Whenever it is there, look for a vulvar carcinoma, vulvar adenocarcinoma, cervical adenocarcinomas, vaginal carcinomas, anal and rectal carcinomas, or bowel carcinomas, sigmoid carcinomas. All these are common whenever you have a Paget's disease in the perineal area. You have to look for these primary sources. In 40% you can have these. When it is isolated, then you can plan excision with negative margins, and regions you can look for, as I said, is in vulvar, perianal, and in the scrotal areas you can find this. So other cutaneous tumors, as we already discussed, was angiosarcoma. We had a discussion in sarcomas. So something similar you can have. Most common is in the trunk. Then you have the scalp and head and neck, which is the second most common, and you can get satellite lesions, metastasis, Stewart-Reeve syndrome, as I already mentioned, in the lymphedema associated arm. So the usual duration is around 10 to 20 years post radiation. Post RT type will develop in the field of radiation, epitheliotype in the lower limb, and face and neck are more common in the elderly population. And Stewart-Reeves, already we had a discussion. It's a lymphangiosarcoma in the lymphangium outside the field of radiation. Okay. So in high propensity for nodal metastasis, margins 2 to 3 centimeters are recommended, like your DFSP. So DFSP, we again discussed that it is a low grade sarcoma. In sarcomas, we had a discussion. So it is a 50% are truncal, most common lesion. That is a question that can be asked. The answer is truncal. Gross margin is 2 centimeter. In Schwartz, it is mentioned as 3. but probably for your exams I will go it as 2 centimeters as the margin. Okay, so at least 2 centimeters is what is mentioned in subdistance. So the classical answer is 2. I would probably go with that as the option. So MOS or CCPDMA, this is the one that I was referring to: complete circumferential, peripheral, and deep margin assessment, muffin technique, and the Dubin Torte technique. So those are techniques where you compress and you cover the deep margin. That is your muffin technique. And what you have is your translocation of 1722. 1122 happens in Ewing sarcoma. Here you have your 1722 translocation. So the collagen receptor with the PDGFR is there, and that is the reason why it responds to imatinib as well. In DFSP, there is a good response to imatinib as well. Other rarer tumors, this can be a clinical picture. This is your Kaposi sarcoma, the endemic type. So the classical Mediterranean type usually happens in the extremities. African endemic type, HIV negative, men having sex with men type, and then you have immunosuppression associated, AIDS associated. These are not questions that will come. Kaposi's, they can just give you what is the virus. HHV8, human herpes virus 8. This is an AIDS defining cancer. So what do you mean by the definition of an AIDS defining cancer? So in HIV positivity and AIDS are two different entities. So just the presence of a patient having HIV positivity doesn't make them having AIDS. AIDS is when you have syndromic manifestation. There are a few cancers which are considered to be AIDS defining. So in a patient who is HIV positive, if they develop this particular cancer, then it becomes an AIDS defining cancer. One of them is your Kaposi sarcoma. Any patient with HIV positivity developing Kaposi sarcoma is considered to be having AIDS. Similarly, you have cervical cancer. I have not put it up here, but remember, cervical cancer is another one. Cervix cancer is an AIDS defining cancer. Primary B cell lymphomas, primary effusion associated lymphomas, primary CNS lymphomas, all these lymphomas, effusion lymphomas, CNS lymphomas, head and neck and oral lymphomas, all these primary B cell lymphomas, many of them, they will be called as AIDS defining cancer. So whenever you have HIV positive patient with these, then you call it as an AIDS defining cancer. They can happen with immunosuppression as well. So commonly happens in the lower extremities. Common presence of Kaposi sarcoma will be in the lower extremities. In this diffuse form, it will be appearing as these macular lesions or nodular lesions that develop over time. Treatment is very clear. It is hard. Remember, that has come as a question. What is the management? The management is the management of your, AIDS basically. So highly active antiretroviral therapy. So that is the treatment that is going to be done. The role of surgery is very, very minimal. There is hardly any role for surgery in your this one. So that is the last slide for us, and we have these lesions can be given as a criteria. I mean, as an image-based question. Your Kaposi sarcoma, the management has been asked. HHV8 has come as a question. So these are all questions that have come up. So that, my friends, brings us to the conclusion of the topic, and hope that you can go through this and you find it useful. Any questions that you have with regard to this, please share in the group and I'll be able to answer the questions. I see it's already quite late, 10:30 at night. So heart is highly active antiretroviral therapy. Heart is highly active antiretroviral, ART. Basically, your antiretroviral therapy is known as highly active antiretroviral therapy. So that is the way it is. So basically, you have to treat your AIDS. That is the treatment for your Kaposi sarcoma. Usually, that will take care of the Kaposi sarcoma because it is immunosuppression related. So you manage AIDS, the Kaposi sarcoma will be taken care of, and surgical excision is usually not needed. It's a classical diagnosis. So I hope this was useful to you, my friends, and thank you for your patient listening. Please, any questions or anything that you have and all this. So medullary, do we go for an ipsilateral lateral neck dissection in all cases? Yes. As I said, a lateral neck dissection has to be done. No, not lateral neck dissection. Central neck dissection will be done in all cases. Lateral will be done in patients who have a calcitonin of more than 150. Calcitonin levels of more than 150 is there. Then you have to go for an ipsilateral lateral neck dissection. Okay. Central neck dissection will be done in all cases. Okay. But lateral is done only if the calcitonin levels are more than 150. Okay. So um, thank you, my friends, and I hope that these lectures were useful to you, and all the best for your examinations as well. I am sure there are a lot of rankers. It was one of the most engaging batches that I have had. Very, very receptive, and all of you were there. And even on on a Friday night when all of you can go and party, basically you're here attending a class that shows your dedication. It's like 10:30 at night, and you're here with me. So all the best, my friends, and I'll share the PowerPoints also with you shortly. I'll share it with Rahul and he'll put it up in the group. Many of you had requested. It's basically the same thing as the notes, but I will share the PowerPoint as well and we'll go ahead with that. So thank you, my friends. All the best.